myself. Hi, Chitra. Thank you. Thank you for the opportunity.
Yes. Oh, we become very enriched when we have super experts on the panel.
Thanks.
We are live.
A very good evening to one and all of you for yet again another very interesting ARC webinar on top pearls in cataract surgery. It goes without saying that any amount of information which we get on cataracts is a big boon, a big gain for us. And I'm sure our entire interest in the next 3 hours is to ensure that it's a very gainful 3 hours of learning. With the kind of expert panel we have and the kind of terrific speakers with great videos, I'm sure it's going to be a very enjoyable 3-hour too. We are very glad to have with us joining very soon Dr. Ajay Sharma, who's the Chief Medical Director of the IQ Super Speciality Group of Hospitals based at Gurgaon. We have, who has already joined us, Dr. Kapil Vora, who's the Medical Director and founder of Kapil Eye Hospital, Ambala, a very prolific, admirable surgeon. We have with us Dr. Nitin Balakrishnan, who's the Chief Medical Director at Sai Deep Eye Clinic and Crystal Vision Laser Center from Mumbai. Again, a very prolific, versatile surgeon. We have with us Dr. Bharti, who's again a medical director and chairman of the Bharti Eye Foundation, New Delhi. I'm sure we all know of him, what an amazing national figure and international figure he is. Dr. Mohan Rajan is unable to join us because he was caught up in another meeting. Joining us soon would be Dr. Satyan Parthasarthi, who's the director of the Satyan Eye Care Hospital and Coimbatore Glaucoma Foundation, and again, a very experienced, reputed ophthalmologist. We are truly lucky, I would say truly lucky, to have with us Dr. Minu Mathan, who's a senior consultant cataract, phaco refractive surgery from the Chaitanya Group of Eye Hospitals based at Trivandrum. And with this kind of expert panel, one beat to beat the other, I'm sure everybody, including me, we are going to learn in this course of 2.5 to 3 hours. Co-moderating with me is Dr. Harshul Tak, who is mainly the member ARC Central. He has also been the past, recently he has handed over. He was the chairman of the Rajasthan Ophthalmic Society and did a great job in his tenure there. And he's an amazing surgeon. Words are not enough to describe the kind of surgical skill sets he has. And I look forward to taking this webinar to a different level with him co-moderating with me. Our first speaker is going to be Dr. Tejal Shah, who's a consultant cataract and refractive services from Narayan Netralaya, Bangalore. And let's have her presenting. Dr. Tejal, yes.
Good evening, ma'am. Good evening, everyone. I'm Dr. Tejal from Narayan Netralaya, Bangalore. So I'll be presenting a case of posterior polar cataract today. So this is, yeah. Am I audible, ma'am?
Yes, you are.
Yes. So yeah, this is a case of posterior polar cataract. So before starting the surgery, I had got an AIOS OCT done. So I knew that the posterior polar cataract was adherent to the posterior capsule. I do not have the image, sorry for that. So when I started my surgery, I wanted to make sure my rhexis is right at the center. At around 5 mm rhexis is what I was aiming at, so that even if there is a mishap, it would be easier for me to place a lens in the sulcus. So once I did that, I go on to do my hydro delineation. I make sure I do not hydro dissect at all because I know that it is attached to the posterior capsule. And once I inject any fluid, it can open up my posterior capsule. So once I do a hydro delineation, I gently try to divide the center of my endonucleus, and I try to take whatever I can with very minimal maneuvering. So I do not want my posterior chamber fluctuate or anterior chamber to fluctuate too much. So what I do is I gently crack the center and I remove the endonucleus with very minimal power and with vacuum. So once I do that, I go on to the epinuclear mode and I start to remove the epinuclear plate. So once I'm doing this, my bottle height is around 65 centimeters. So once I do this, I can see that once I peel, you can see that there is a small central opening of the posterior capsule. It's visible once I remove my epinuclear plate. So once I do this, I gently try to remove the other part also. So I do not want to maneuver too much. So once I remove the epinuclear plate, I go on to my IA. But before removing my phaco probe from the anterior chamber, I want to make sure I put in visco. The anterior hyaloid face is not being disturbed because I can see when I inject the visco also. So the PCR did not enlarge once I put visco and removed it. So I gently did an irrigation aspiration, removed all the residual cortical matter that was present in the eye. And after that, I injected a single piece hydrophobic IOL in the bag. Since my posterior capsule rupture was more like a PCCC, it was easier for me. It did not enlarge. So I put adequate visco and I injected the IOL in the bag. So this was my case of posterior polar cataract. Thank you, ma'am.
Yeah. Wonderful presentation, Tejal. You did a great job of it. You said all the relevant features which have to be said. Not directly in your case where there is already an awareness of a posterior capsular dehiscence, but in a situation where you know that there's a PCC, but the posterior capsule has not dehisced. At that point of time, if you have partially evacuated some of the nuclear fragments, would any of you in the expert panel think of doing a visco dissection at that point of time, or even a hydrodissection so that those pieces become more mobile and remove it? Would you consider that? Would you advise that? Whom do I ask? Dr. Meenu?
Yeah, thank you, Dr. Chitra. Very great presentation. Looked like such a clean case, but it's not as easy as you showed it. Especially when the PC is open. So I would not do any hydro procedure. Although doing a visco, I'm coming here. Visco delineation is good. It can release your adhesions in the periphery. Epinucleus plate will become more mobile. That's all true. But in my hands, I use a 2 millimeter blunt-tipped chopper, which I use for my regular chopping, to go around underneath the rhexis margin to manually move these pieces, this epinuclear layer from the periphery gradually. And after releasing all around 360 degrees, then only I aspirate. Okay. So it can be done. It is very safe. It gives again a protection and also a mobility of the epinucleus. One more point which I noticed in that one was I saw in between you aspirating with the vitrectomy cutter. So that is good thing to have. You can cut the vitreous if you get vitreous. But for me, the opening of any vitrectomy cutter is larger than the IA tip. And so it is more difficult to get an occlusion if it is thin cortex. So if you are not expecting vitreous, I would go ahead with the IA itself. And then when I see vitreous, I can always use a vitrectomy cutter and stop cutting when you finish vitrectomy. Nice. And again, sometimes we feel the edge of the PC opening as fibrosed. But to take the words of Dr. Bobby Osher, who's an authority in posterior polars, he still believes that the edges of these posterior polar cataracts are the openings of the posterior openings of these posterior polar are still weaker than a PCC, and the fibrosed part may look fibrosed, but they can easily give way. But the way you injected the lens inside without rotation was great. So if you place a lens into the bag with the haptics folded, so that it opens slightly into the bag just like that and not rotate it and dial it, then it stays almost well like that. But then be little careful about the edges, although they look fibrosed and very nicely round.
Okay. Yes, Dr. Kapil, would you want to add something to it, or shall we go on to our next question? I think he has
explained. I think a very difficult case made very easy by the surgeon. Beautiful surgery done. Nothing to add except for that I would like to make my capsular access slightly oval, because many a times with the small capsular access that you have made, doctor, the fluid gets entrapped behind and the pressure increases inside the bag, and that may give rise to a rupture or extension of the circumference. So what I do in my cases is I make a slightly oval access as described by Dr. Kiranjit Singh, so that there is a pathway for the fluid to escape. Rest of the surgery, excellent.
Would you
Dr.
want to take the
Tejal?
question? Yes.
Yeah, Dr. Tejal, did you use tricot in this case?
No, sir, I did
Yeah.
not use tricot.
Okay. I think
It was
ideally
quite
one should.
visible that, yes, I should. It was
Yeah.
not visible, so I did not.
Yeah. So
Yeah.
one should always try to use tricot. And secondly, as Dr. Meenu said, one should always know the cut IA and IA cut mode in the vitrectomy settings. So if you're comfortable and cortex is not that thin, you can very well do the way you did, use the same cutter to aspirate, and wherever you need, you can cut also later on. So you should know how to set up those settings in your machine. And of course, the most important principle is to maintain the anterior chamber. So that was very well done. And I think this is a perfect educational video how to deal with posterior polar cataract.
Yeah. Dr. Nitin, in a case when you already aware on ASOCT that there is a PC weakness, posterior capsule, would you have anything extra to add over what was already told in the epinucleus management or anything? How would you do anything differently?
To start off with, that was a lovely video, a very, very well done case. But things can't be as simple as this always. I think it's this entire topic is an encyclopedia by itself.
Yeah.
The only thing is, once you know that, like Dr. Tejal has already explained, one wouldn't do a hydrodissection. It is better to go in with a hydrodelineation. And like Dr. Kapil Vora said, a oval rhexis, so that one axis is longer as compared to the other. You don't need to, the smaller axis could be a 5 millimeter, but the longer axis could be about a 5.5 millimeter. In the nuclear management, a visco dissection, in the epinuclear management, a visco dissection, or rather a visco delineation in case of it's fine, because here the epinucleus came out very easily. But in case the epinucleus is sometimes very challenging to get the epinuclear fragments out because you're not hydrodissected. So it's better to do a visco delineation at that stage, so that and loosen the entire epinucleus from all 360 degrees going below the rhexis.
Yeah. The other thing, the last thing, I'm sure all of us would think on the same line. These eyes, even if you feel that there's a little PC polishing could be done, I think none of us should be doing it.
It should be left alone. It should be left alone.
So Dr. Kapil, one question to Dr. Kapil. So if you make a oval rhexis, how do you do optic capture if the tear is in the same? Usually what we do is we always keep the haptic perpendicular to the tear, and then we can capture it. We can't hear you, Dr. Kapil.
You have to unmute yourself.
Okay,
Yeah.
okay. In the oval rhexis, what we usually do is that we implant the lens 90 degrees to the longer axis,
So
so that captures the optics beautifully.
Tear is in the same line.
Not in the same, not in the elongated rhexis, but towards the shorter rhexis. Say if it is 5.5 and 5.5, so we would like to implant the haptics on 5 millimeter side of rhexis.
No, then if you implant it like that, then optic capture is not possible.
Because rhexis they already made.
Usually with 5.5 millimeters, most of the lenses are 6 millimeters that we use nowadays. The optic capture is there.
No, I have a feeling we should place the IOL along the long axis, that is the larger part of the rhexis, so that.
Yes, but what we are doing is we are implanting it at 90 degrees to it. And yes, that's also true that if you implant it in the direction of the longer axis, it will capture well again. Yes, because the haptics are there to support that.
Yeah, I too think I too will go
Yeah, I
with
agree
Dr.
to it,
Chitra's opinion. That I would place it into this one. And also Dr. Harshul, wherever the PC rent is, I don't mind placing the haptics in the sulcus in whatever axis. The PC rent location and placing the haptic, I don't think it matters. So that doesn't matter. But then the shorter side, I think, should come at the sides of the optic so that more optic goes underneath the rhexis margin.
Rhexis margin. Yeah.
Thank you. We shall go on to our next speaker, Dr. Lubna Zamir, who's a consultant cataract surgeon from Narayan Nethralaya, Bangalore. And let's have her video. Dr. Lubna. No, I'm sorry. Yeah, Lubna. Yes, Dr. Lubna.
Good evening, everyone.
Can you share your screen?
Yeah, just now.
Warm welcome, Dr. Ajay.
Yeah, thank you. So I'm through
Traveling, I think.
on a Zoom meeting.
Yeah.
May I begin my presentation?
Yes. You can present.
Yes, so this was a scenario which was being discussed with me by one of my junior consultants, and with her permission, I want to share this funny scenario with you as well. So this was a 61-year-old patient undergoing cataract surgery, and most of the phaco was going on very well, and there were no other comorbidities in the eye, and certain scenarios in this are encountered by all of us, but this is a clubbing of multiple scenarios coming together. So hence it's an interesting one. So once the phaco was done, she moved on to do the irrigation aspiration, and as she was just heaving a sigh of relief that it's almost done and now IOL has to be placed, she realized that one of the haptics is broken. So yes, sometimes it happens. So she used her due diligence and decided to remove the IOL, and for the same, to remove it through a small incision, she decided to use a lens cutter. So all seemed to be going pretty okay. Even the lens was cut into decently 2 pieces. And most of our focus at this time is generally on the lens, that how the lens is being cut and it's being brought out. Yeah. And then she opts for another lens to be placed in the place of this lens which is being removed. So all seems to be going on fine. She implants another lens. And while she's dialing and doing irrigation aspiration, she notices there's another issue waiting to be handled. So there is a PCR ready to engulf the IOL. She goes on again to remove the IOL which is about to be dipped inside. This time she extends the incision further and removes the lens. And then followed by, because the rent was such a huge one, she decides to go for vitrectomy. So she does a thorough anterior vitrectomy. And because the anterior capsular support seemed to be pretty decent, a 3-piece IOL was placed in the sulcus. So what makes this video a little interesting is there are multiple scenarios that come one after another to be handled. And yes, the IOL is placed in the sulcus and the wound is secured with the help of a suture. Thank you so much.
Thank you very much, Dr. Lubna. That was multiple learnings which came in this case of yours. Could you stop sharing so that we could have a discussion? A very good teaching video. Dr. Satyan, are you there with us? Yes. Dr. Satyan, one I wanted to ask Lubna, was it a high-powered IOL that because of which the haptic got cut? Because sometimes when the lens is very thick and big, it could happen. What do you think would have been the reason for the haptic getting cut?
Ma'am, many a times I think because during the loading of the lenses, if the haptic gets captured in the clips of the cartridge, many a times that can also be the reason why the haptic gets cut. And
overall, the cartridge also can cause the haptic to get cut.
Sometimes yes, sometimes yes. And overall, there was no such issue with the. It was pretty a normal cataract case which was taken up.
Dr. Satyan, could you think of reasons why you could have a haptic breakage beyond what we thought of?
Thank you, madam, for inviting me.
when you have the, I think you had asked a very relevant question on is the patient had a high myopic? Because once the patient is high myopic, obviously we know that the lens thickness is going to be much more.
Hyper. I'm sorry.
Hyperopic.
Okay, the lens thickness is going to be a little bit high. So when you're loading the lens, it's a little tighter. And if you don't have a good injector, it gets locked, and then obviously you'll have a damage to the haptics. It is quite often seen, or if you have selected a wrong, the injector, then you will have this problem. Tight injectors, very less viscoelastics that you have put in, and then the injector tip has gone in up, and then it gets locked in. So these are the very commonly seen problems. But if the surgeon is able to load most of the time, then these complications can be avoided much. But having said that, I really don't do the loading part of it. Most of the time the staff does it. So that's what I think. Once you have an improper loading, or your injector is not good, or your cartridge is not good, and you have very less viscoelastics injected into the cartridge, then you will have this kind of problems.
So what are the challenges in cutting this IOL? What are two simple things which we should be taking care when we cut the IOL? Any of the expert panel could answer.
Yeah, I would hold the optics
exactly.
with the microservices for success to the paracentesis. Second thing is, I will find out after taking the IOL into the AC, if the pupil, sometimes pupil becomes very small. So you don't see what is happening in the periphery. Put iris soaks and see, visualize. If there is a precedent or something, then deal with that also. Otherwise, I'll implant another lens first. And on the scaffold of it, take out this, and then second place take this out. So the scaffold has to be there to prevent this PC rupture happening with the tip of the. My point is that I have had haptics cutting only in two scenarios. One thing is, the commonest is the tip of it getting into the flanges of the butterfly, and butterfly get closed. So to avoid that, after loading, I always see it under the microscope, see both of the haptics which are lying next to the optic, and see both of them moving while injecting. Then nothing will happen. The second thing is the plunger tip, which is a silicone tip, which moves over the straightened haptic. Haptics become straightened, not folded, and this will move over it, and then it will reach into that tight bottleneck area, and then you apply more pressure, and it gets severed from the haptic-optic junction.
Yeah. And which kind of, sorry, Harshul, I'll just take this question. Which kind of IOL would you, like in one she cut it, in one she did a hand over hand technique and removed it. So which kind of IOL material you think facilitates a hand over hand, and in which would you cut it? I think I would believe
hand over hand. I never do hand over hand, because I believe it will distort the incision. It will distort any incision by pulling it. There is no need to pull like this. And also while cutting, make sure we cut it at least by half. This one, we would have noticed it was 1/3, 2/3. Still, you may need some extension. So if it goes to 3.2 or 3.5 also, doesn't matter. It closes very well. Anyway, if it's a piece and you're going to suture. So there is no point, according to me. But I agree, some people do it hand over hand. But according to me, there is no need to pull out the whole 6 millimeter through a 2.8 or 3 millimeter.
Yeah. Any other different opinion of the expert panel on that?
The only thing is, in the especially if it is an Acrosoft lens in these cold climates, when winter sets in, sometimes these lenses are very, very difficult to open, and at the same time difficult to fold also. So an improper folding at that stage, and especially when the plunger of the injector rides over the optic or over the optic with the haptic placed on the optic, very often if it is not pushing the lens but is riding over, you find that there are high chances of these breakages of these haptics. So it's important to warm these lenses, the hydrophobic lenses, especially if you're using an Acrosoft material, especially in these types of seasons.
And
I have okay, sorry.
Yeah, please, Dr. Kapil.
No, after you.
No, I was just saying one more point, what Dr. Minu said, no, it's very important to look for the optic. And after that, when you are pushing the IOL from the cartridge toward the tip, you should always feel the resistance, how much resistance. If there is undue resistance, that almost always means that either plunger is overriding the optic or something is wrong. So if your assistant is loading the lens, so tell him not to push it till the nozzle, tip of the nozzle, so that at least you can have a feel that yes, how the lens is advancing. That's what I do. And second thing, Dr. Lubna, is when you are taking out the second IOL from this, I think before that you should do vitrectomy, because you're pulling on the vitreous. When you are taking out the IOL without cutting the vitreous, there's a lot of traction which is going on toward the vitreous base. So
Yes, sir. I'm actually in charge of the FECO thing over here. So this was one of my juniors.
Yes.
So I pointed out 2 points over there for her. One thing is that she should have, like Dr. Minu said, that she should have checked for any post-capsular rent before going in with the second IOL. This is a major mistake, because the rent was not so small that it could have been missed. And the second thing I feel is that if you need to extend the incision, you must always do so instead of trying to just pull it out through a 2.8 or a 3 millimeter incision. That's absolutely not right. So this is definitely what I wanted to point out through this video as well.
Yeah.
It's a do and die, if the stage when people see it sinking, so somehow they catch it and they pull it off. As Dr. Harshulta is telling, that is a fantastic point, that you should feel the resistance, that if it is more than what you generally feel, there is something wrong, and please recheck what is happening. And this one also, as she was telling, the looking for the PC before taking it out, very important before you try to implant another one.
Yes. Madam, I want to add 2 more points.
Yes.
Just my experience. We can remove the lens through 3.2 mm incision. If you enlarge the incision with that your tooth forceps or any tooth forceps you can use, and you can remove the lens after twisting it very easily without any suturing is required. And second thing, through SICS incision also you can remove.
Who's
you can take SICS incision and you can take out the lens very easily.
Okay.
Dr. Chitra, can I add something?
Yes, Dr. Ajay. Yes.
Yeah, so I think with the type of lenses which probably was shown in the video, so when the plunger, when you're going in, when you loaded the lens, so you push it first and let's see the plunger, you can pull it back so that you see the lens lying there, right? So that will most of the time save you from these haptics being broken. Secondly, holding it with the microforceps, and this is one way which was mentioned, but maybe when we are cutting it, I suggest you should with the scissors, micro scissor, you should take a very large bite for that, because larger the bite, the sooner it is better. And you can even use a hook. When we are cutting it, it has a tendency to be pushed towards the inferior part. So when you have a hook which with that hook you pull it from the inferior side and you make it sort of a stable there, and easily it can be cut, and then half of it can be taken out. But yes, I don't recommend just pulling the lens out without increasing the incision size. Just to add to it.
Thank you very much.
Chitra, I just wanted to add one thing. To this, that what I would like to share is that the marriage between the injector and the lens has to be perfect, number one. Because most of the time such incidents are happening because if we don't use the prescribed injector, we try to inject it through some other injector, because there is a perfect ratio through which the lens can be pushed. So the injector or the cartridge has to be of perfect size. And most of these companies, what they do is they outsource the manufacturing of cartridge. Right? They buy it from one vendor, then from the other vendor. The shape is same, but inside lumen is different. Because this happened to me in a series of lenses and with one particular company. And then when I inquired, this was the thing, this was the outcome. So this also we have to keep in mind.
Yes. Thank you very much. We shall now go on to our third speaker. Thanks, Dr. Lubna. Our third
Thank
speaker,
you.
Dr. Sumit Sachdeva, who is the professor of the Department of Ophthalmology from PGI Rohtak. And he is going to show us another interesting case. On to you, Dr. Sumit.
Yeah. Is my screen visible, ma'am?
Yes, yes.
So good evening, everyone. And I thank Dr. Chitra for inviting me to this meet. And I would be telling about a complicated cataract. We had an interesting case. A young person had a uveitis for a very long period. And you can see that there are posterior synechiae 360 degrees all over. And what we had planned a cataract surgery, the posterior segment was normal on ultrasound. So the challenge here was a shallow AC with a very dense cataract and a small pupil. So what I did in this case was that after making a side port, I just injected the trypan blue dye, and then I tried to open up the pupil. There was a membrane which was sticking, which was adherent to the membrane was at the pupillary edge, and I tried to remove it so as to just dilate the pupil somewhat. And I was fairly successful in removing that membrane, and we can see that the pupil has dilated. And after that, I had a reasonably good pupil size. The other challenge was the rexis, because the pupil, the lens was pearly white and it was not stained well. So what I did was I just started the rexis with my cystotome, and then I shifted because I could not see it beyond that. So I just shifted it with my Utrata forceps and started doing a rexis, completed the rexis, slightly smaller, about 5 millimeters in size. And after doing a thorough hydrodissection, here I'm using a Chang cannula, just going inside the edge of the rexis. You can see the pupil trying to come out from the main port. I had made a larger main port. Now we have a very shallow AC. I started my phaco. I did a direct chop here. And the key here is just to bring the fragments to the center rather than chopping, rather than eating them away at the periphery. So I just brought every piece slowly to the center. I was going slow because of the shallow AC. I didn't want to hurt the endothelium. So here I just by one, taking out the pieces. Now, the problem here, the main thing here is that the pieces being large, they just tend to, stick to stick at the periphery. So you have to just pull them together, pull them out in the center, and then take them. So after, yeah. And we have to go slow because you never know what's behind, because it's a complicated cataract for a very long time. And after taking out the last piece, I just check that everything is fine. Yeah. So the last piece was taken out, and there was hardly any cortical matter left. And rest of it was quite simple. Just put in an IOL, single piece IOL, and just close the first. So at the end, it looks quite okay. But when we started, we didn't know that we would be reaching this stage. The person actually gained a good vision after cataract surgery.
Thank you, Dr. Sumit. That was again a wonderful video. I mean, it is definitely a teaching pearl that you do remove that pupillary membrane, because you do get a fair amount of dilatation, inflammatory membrane, you do get a good dilatation. But the only thing I felt was, I mean, maybe I would have done that too, but when it was an intumescent cataract, and ideally we would have not opened up the main incision if it were not for the small pupil situation, because you needed. So, to take the rexis, if you are done with your micro forceps through the side port,
Yeah,
And
that would have been better.
to the main port, you could have had after such as the first initial step, you could have had a Rexis running off.
Running out, right.
Was there.
Actually, at that time, I didn't have that Rexis with me. So I just did one method. Right?
The other thing is in these it's a shallow AC and possibly it's a hypermetropic eye.
Yeah.
How many of you, Dr. Satyan, would you want to take this? Would you want to give a pre-operative Dimox or an oral glycerol, and from which level of anterior AC depth or axial length would you consider adding that in your pre-operative medication?
Regarding the anti-glaucoma medications, it all depends upon how much is your.
Yeah.
So, yeah, that depends upon your intraocular pressures. It is not the AC depth which is going to determine this, because the moment you just go in, then you make a small opening in the pupillary area, the AC will become better, definitely, because this is sinus A, the posterior sinus A with the 360 posterior sinus A. It's something like an occlusive pupil.
No, not this particular case.
Okay, you are asking general.
Any hyperopic eye.
Okay.
From what level of hyperopia would you consider decongesting the eye and by adding oral glycerol? Would you?
Oral glycerol, at least I never give oral glycerol. Probably Dimox or an IV mannitol in case of high IOP. Or say, for example, you have an anophthalmic eyes. Of course, that is completely different scenario. We will talk about that later in case if we have some time. But in otherwise, IOP, normal IOPs in the high props, we have to be just cautious rather than giving all the other medications as such.
Yeah,
So
we do in a shallow anterior chamber less than 2.2 or a small axial length. We do give oral glycerol to our patient before the surgery, unless they are a diabetic, and it has helped us a lot. I mean, there's rarely a situation where we have needed to give an IV mannitol during the case, because many of these patients are cardiac patients. So I just wanted a diverse opinion so that we know to start thinking in a diverse manner.
So is that you feel that oral glycerol is going to have a significant change? Is it?
It does decongest the vitreous, and vitreous, if it is decongested, there's less of positive pressure during the course of the surgery. It is
what I would look at is the wound, the pattern of wound. What you do is, so making a very short wound, we'll have to make a little longer wound so that the iris doesn't come in very often. Both the side port also. Make sure that the wound is not, the size of the wound is not big, but the width of the wound may be slightly bigger as well as the side port, so that the chamber is reasonably tight. It's not, like a very leaky. The very leaky ones are going to be very hard for you.
Ones are totally out, yes.
How much of oral glycerol do you give, Dr. Chitra, and how
just
long
1
before
ounce.
the surgery?
Just 1 ounce, and it has helped not just me, all our surgeons in our hospital find it a remarkable relief. And we have started, made it as a routine protocol for shallow eyes and short axial lengths, and it does make a difference. I mean,
about half an hour before? About half an hour before?
Yes,
half an hour before.
half an hour before.
Is it better than mannitol, ma'am?
Mannitol is for cardiac patients. Actually, I'm sure the more we evaluate these patients pre-operatively, we find that majority of our patients are diabetics and majority of them have a borderline cardiac status. So mannitol, I think we have to keep at the point of time when we have had a hard intraoperative hard eye, or those kind of scenarios when we actually need something very significant to bail us out. So it is just.
Can I add one point?
Yes,
yeah, sir, very nice case, sir. To start off with the pupil, which was small, the reason for these kind of cases is either a sinus A or a diffuse membrane over the anterior capsule. So that can be identified only if we touch on the pupillary margin and identify the membrane. Yeah. Once you remove that, only this capsule stains well. So nowadays, I do not put in stain in the beginning. So I put in sodium hyaluronate, which can be easily taken out. Or you can create a plane of saline underneath that after dilating the pupil. See, either dilating is by hooks or stretch, or by removing the membrane. So if you get an adequate 5.5 millimeter pupil, then after that I put saline underneath the sodium hyaluronate. and then paint over the, because we need to stain the mid-periphery of the anterior capsule rather than the central 3 millimeters. So that is one point which I always do. Otherwise, we can always wash the the sodium hyaluronate out. But the HPMC, if you put, it is very difficult to wash it off from the anterior capsule. Piece by piece, it will stick everywhere. Very difficult to take it out. So that is why I put sodium hyaluronate inside first. Second thing is, as madam was telling, see, nowadays I look at the intumescence of the lens and then decide whether to dehydrate the vitreous. Dehydrating the vitreous will give us, when you push in visco into the anterior chamber, will give you more anterior chamber space. It is not to reduce the IOP. It is not to reduce high IOP initially reduce. I am getting more space to flatten out the anterior capsule in a convex configuration of an anterior capsule, which is there in intumescent lenses. And so that is why I give mannitol. And madam, in all these what we consider cardiac, most of the physicians and cardiologists don't consider them bad cardiacs. So, the cardiac failure people, if you don't want to overload, then only you avoid mannitol. Otherwise, most of them, because we are sending every of these patients to get fitness from physician for mannitol, and I find that they give. You can easily give 150, 200 ml to a moderate sized adult if they are not in failure or very bad ejection fraction and all those. So mannitol is a very good tool, or oral glycerol is.
Go back and give oral glycerol for some
very difficult to drink. Have you taken oral glycerol?
No, I haven't taken. But
oral glycerol.
You have to
but as a medicine, people should take lemon juice, and as a medicine, people should take.
It cannot be
taken. I think I'll try that in some of those people.
And you see, it helps a lot. The other question is, going back to his specific case, would there be any difference in the anti-inflammatory, like perioperatively inflammation control in the follow-up period? Would you all do anything extra for these patients? It is an old inflammation that comes clear, but would any of you all add anything at all to these patients?
I generally start steroids a day prior to a day or two prior to the topical steroids.
Yes.
That is.
Yeah, you could start topical
steroids. Yeah, we use topical steroids 2 days prior to the surgery, so that at least some of the inflammation is.
And if there is a little more evidence of PS and all those kind of things, then we would have to keep them on a longer period of steroid drops if we have not evaluated them for their any probable uveitis and any systemic issue. So that needs to be done. And Harshul, before you take your question, one last question. Some of these cases of these inflamed eyes can have some pigments on the lens later on. So how would you all manage, again, any of the expert panel, those pigments on the lens? They may not actually be visually disabling, but sometimes they can.
Yes, they are there.
So how would you all like to do it? Dr. Nitin, Dr. Ajay, any of you can tell me? Anybody?
Fine pigments, I don't do anything. Fine pigments, they just go off with time. But there are pigments surrounded by gelatinous kind of protein precipitates. That in the visual axis. Okay, so those will affect vision. 624 can become 6.9 if you do a yak sweeping. But I don't do yak sweeping early. So I wait for at least 2 months, 6 to 8 weeks of topical steroids. See how his anterior chamber is very quiet.
Dr. Santosh,
Agarwal.
Dr. Santosh, you have to mute yourself. We are hearing.
Okay, sorry, ma'am. Sorry.
Okay, and so our uveitis specialists in some cases start oral steroids before surgery. So we maintain 2 or 3 days post-op and see how the reaction is and taper off very fast. Or even we give an intra or in the theater on the table 1 IV DEXA for the first day, and we see by evening and the next day morning, see how the reaction is, and then titrate the steroids, either systemic or topical, according to the response of that particular person.
Yes. Dr. Harshul, anything extra we have not covered on this before we go to our next?
I think everything has been covered. Just one last question from my side, that if the patient has a shallow anterior chamber like this, would you like to do that case under peribulbar block or topical? Dr. Meenu?
No, shallow chamber doesn't make me change my option on topical or this one. But if it is a very uncooperative patient because of a mature cataract and they cannot focus properly onto a light, and if they are keeping on moving, then I would block. Otherwise, this is a younger patient, softer cataract. Only you just need to know the pupil. So I would put, if it is very shallow, I would use iris hooks rather than dilating device rings if you need to. But if it's dilating to this size, I need not actually use.
Madam, can I add one point?
Yes. Who's
Word
that?
of caution is we should go for B scan before taking this
Yeah.
patient for
That was
cataract.
mentioned.
I
Yeah.
already
Yeah, that was
mentioned.
mentioned.
Okay. Thank you.
Thank you very much. I think Dr. Ritika's video will take towards the end. Harshul, do keep that in mind. I
Yeah,
think
yeah.
she's on a flight in case she's not able to join in. One of her colleagues would present it. We shall now go on to our next speaker, Dr. Nivedita Narayan, who's a cataract, corneal, and refractive surgeon, a senior consultant from Shankar Nethralaya, Chennai. And she is going to present us a very challenging, nice case. On to you, Dr. Nivedita.
Good evening, everyone. Thank you, Dr. Chitra, for giving me this opportunity. Here I'm presenting a very challenging case, combined DMEC with phaco. The patient has a bouquet of complications, corneal haze, shallow AC, situation post-YAC-PA, non-dilating pupil, and a very dense bound cataract. It's a Fuchs patient. I'm using an iris hook here. The capsule is stained. Still, the visibility is not good, so I'm removing the epithelium. It's a diabetic patient. We can see how easily the epithelium is peeling off. So only in the center, I'm removing the epithelium to enhance the visibility. Still, I feel it is not good enough. There is a subepithelial fibrosis though. So I'm not able to see my cystitome well. So I started an endo elimination. So if you show the endo eliminator little sideways, you can see the capsule very well. So that helped me in doing my capsular excess. That is one way of doing it. Other one is you show it at the limbus, you'll get the retro reflex. Here I have switched off the microscope light. I do direct chop with the Appasamy Rajan chopper. So I'm chopping the cataract into tiny bits. The only blessing in this case is I don't have to worry about the endothelium. So I'm going to get the small pieces onto the chamber to make sure I don't end up in a rent. Because I know at the end of the case, I'm going to change the endothelium. So I'm consciously bringing them up. So that visibility is better. So after cortical wash, I'm inserting the lens. It can be done with the endo eliminator, or you can have a microscope light also. I have done it with the light pipe here. So this is a monofocal lens, aspheric thickness. I don't adjust the IOL power because that's what I have found in my cases. For DMEC, it's not necessary. This is Descemet stripping, 8 millimeter from the side port, roughly around 7.5. So I'm removing the Descemets. Now this is the loading into the cartridge. So very important is the orientation of how it is rolled. So that should be remembered so that unfolding becomes easier. I have made an F mark here. Nowadays, I don't do an F mark. I just do an L mark using a simple spatula. I don't even do a stromal punch. I just mark it on the folded Descemets so that the stroma can be used for a DALC. So I do 2 corneas from single donor. So then unfolding by gentle tapping. Since the PA is already there, so I'm not going to worry about that. And then you can do an air injection. In certain situations, I use C3F8. And the patient was doing fine. Thank you.
Thank you very much, Dr. Nivedita. That was, yeah, truly, each of these videos for that matter need a clap. I mean, each is so different and varied. Would you, you have done very, very well with the kind of illumination transconjunctivally you have shown. Would there be any other way of giving a better illumination? Is there a possibility? It's just a question I wanted to ask. Maybe you or anybody in the panel.
See, I have been routinely doing that.
Yeah.
And when you record it, it may not seem that clear. But when you see through the microscope, it really helps. So you have to see it once to actually do it. The recording, you won't see the effect. But intraoperatively, it is a big help.
Yeah.
And it is simple.
And the removal of the epithelium, which you did, which edematous epithelium, you used glycerol to remove it, or how did you?
No, that's a diabetic patient with the stromal edema. The epithelium just peels off.
Okay.
With a Vexel sponge, if you touch, it will start moving. And then you just peel it off.
But in any other patient, if it doesn't come off easily, what would you do?
You can use alcohol. Alcohol you can use. You can gently scrape also with the hockey stick.
Oh, okay.
That is a little more rough. Alcohol is safe.
And since this is a very cornea case, I thought I'll take the third question from you. When would you decide to use a DMEC or a DSEC? Would the poor visualization have a role play in any of these?
Yeah, as we have noted in this case, there was a subepithelial fibrosis. The earlier school of thought was to not do a lamellar surgery or an endothelial keratoplasty because you have a subepithelial fibrosis, and that is going to obscure the visual outcome. But over the period of years, we have learned the benefit of endothelial keratoplasty overrates the whatever problem that we are talking about. So patients do benefit on a long run with endothelial keratoplasty. Having said that, differentiating between DSEC or DMEC doesn't matter. It is basically on the surgeon's choice. I have almost stopped doing DSEC. Even in tough cases. This was one of my initial tough case which I've done. Nowadays, even for an aphakia or an eye syndrome, I only do DMEC, and it is possible to do. So whenever it is possible, go for DMEC is my option.
Right. Harshul, do you think we have any other question to take on this, or Dr. Meenu, anything, any of you?
Yeah, the only one other option what you were asking is to use a chandelier illumination from the pars plana. But if it is a mature cataract, then you may not get any red reflex from there. Yes.
Pars plana, I was not saying. You can just.
No, I'm talking about the alternate way which she asked. This one is very well through the limbus only, our endo illuminator, and we are talking about the self-retaining chandelier illumination which goes through pars plana. You can retain it there, and you'll get red glow if it is not such a mature kind of cataract. All the others you will avoid the scatter from the cornea. And if anyway, if we are going to do get a lamellar surgery, then we don't have to bother much of the original endothelium, and so we can be a little bolder in doing surgery. That otherwise, we will be very careful in doing it very slowly, using more of viscose protecting the already damaged endothelium and all this. But otherwise, this is very beautifully done. Very, as she said, when you look at the moonlight illumination with the endo illuminator, then only you will realize under the microscope so nice. Only thing is when the third person is holding it, it doesn't shine the whole anterior chamber. So it has to be focused to the area where you are doing. So our movement of the globe should be limited so that they can also follow our movement. Because if we move more, this illumination will change its location and we may not see it for some time. And even cortex aspiration is again, we have to move it in different directions to see. Sometimes I make a paracentesis and get it into the anterior chamber also because it is a sterile thing. So you can direct it in different directions and look for cortex in the periphery and aspirate with that. Very nicely done. Very, very classic kind of case.
Thank you. So only thing is,
Dr.
we are not
Kapil,
planning for an endothelial keratoplasty here. We want to preserve the endothelium in that case. We have to make even tinier pies of the cataract and aspirate it in the bag slowly. That's the only thing. That's how I would have done.
Yes. Dr. Kapil, would you have anything to talk before we move on to our next case?
No. Beautiful surgery, Dr. Nivedita. Excellent surgery.
Thank you.
Yeah. Harshul, shall I go on to the next?
Yes, ma'am. Yes.
Again, we will be calling Dr. Atul later. So Dr. Atul and Ritika are for the later half. Let's keep them in mind. And we shall now go on to Dr. Ankit Agarwal. He is a senior consultant at the Prayagraj Eye Clinic as a phaco-refractive surgeon. and he's going to show us another challenging case. Dr. Ankit?
Good evening, everyone. First of all, I would like to thank Dr. Chitra and Dr. Hashultak, sir, and all the panelists. I am presenting a case on a small pupil phaco using Made in India pupil expander. I don't have any financial interest in any of this product. Now, this is a patient with chronic anti-uveitis associated with ankylosing glaucoma. Now, the IOL was 28 diopter, so we can see it's a hypermetropic case. First, I put a very high density viscoelastic in the AC, and using the iris appositor, I break the posterior synechiae. Now, injecting the expander in the AC, it is injected just like an IOL. We have to keep the iris appositor above the injector below the cornea so that while injecting, its ends should not touch the endothelium. Now, the four flanges are tugged at the pupil margins. The rexis is completed. About 5.5 mm rexis can be made. Hydrodissection is done, and phaco is performed using the normal technique, which may be direct chop or stop and chop. Now, since this was a uveitic case and the bag was a little moving around when I was doing phaco, I did not want to do IA at first. First, I injected the lens in the bag. Once the lens was secured in bag, I explanted the injector by untucking it from all the flanges, and with the same technique, we have to keep the iris appositor above the injector and below the cornea so that while explanting, its ends do not touch the corneal endothelium. Now IA is performed and the residual cortex is removed. Now some intracameral pilocarpine is put and stromal hydration is done. Now this is the patient taking alpha blockers for last 20 years. So I was suspecting IFIS, and even after putting for 1 hour tropicacel, the patient did not get dilated. Hence, I decided to put an expander in this case. Now, the phaco is performed normally, and after putting the IOL, the expander is explanted using the same method as shown previously. Now, because the iris is very floppy here, first I will put some intracameral pilocarpine to constrict it, to reduce its floppiness to create its tone, so that while removing the expander, it does not prolapse. And IA is performed normally, and removing of all the viscoelastics. The take-home point from this was that we should not be afraid to use expander in cases of small pupil and suspected IFIS. The technique of implantation, engagement, disengagement, and explantation is easily reproducible. And we should always keep AC filled with high density viscodispersives to protect the endothelium. Thank you.
That was a wonderful video, Dr. Ankit, and so gracefully done surgery. Very good. Now, just a question I would ask Dr. Kapil. Now, in these small pupil cases, unless in an IFS we would not stretch the pupil, would you believe that you would want to stretch the pupil in some of these small pupil cases and then insert your pupil expander, or you feel that makes no sense and there's no need to do that?
Chitra, I don't have much experience with pupil expanders, to be very frank, because I have been doing my small pupil cases without any help.
Yeah.
And till now I've been able to manage it somehow. But I would not like to stretch the pupil, to be very frank. I would not like to stretch the pupil at all, and I would not like to disturb whatever structure of pupil is there. If you have to put the iris expanders, you just have to respect to what extent the pupil will go or expand with that kind of iris structure. And you have to manage within it. And most of the times we get more than 5 millimeters of exposure, which is sufficient for a surgery. Because if we stretch, there are more chances of floppy iris and the iris coming into the womb.
Yeah. Dr. Satyan, would you prefer to use iris hooks mainly as against a pupil expander? And in very small pupil, if you have used a pupil expander, don't you think what should be the tip we need to know about placing the last scroll in place?
Well, I just wanted to, tell a few other points before answering the question. One thing is when you have a small pupil, there are two different types. One is the rigid pupil,
yes,
like in pseudo exfoliation, and another is the synovial meiosis.
Yeah.
When you have a small rigid pupil without any synovial, I rather sometimes, I have not used much, like what Dr. was mentioning. I have probably in this 30 years, I used probably 3 times or 2 times I used the pupil expanders. Though we have so many patients, like what you're saying is about 4.55 mm people we can easily manage once you are reasonably comfortable in doing the package. But once you have a small pupil with a synovial, once you go for the stretch pupilloplasty, that will really do very well for you. But those with the rigid pupil, if you do the stretch pupilloplasty, your pupil will become very small. So this message I wanted to tell you. Rigid pupils never go for a stretch pupilloplasty. You can go for if you want the hooks or whatever the methods you can. But in a synovial meiosis, you can use stretch pupilloplasty. That will be really, really very useful for you. These are the 2 points which I wanted to make.
Okay.
Coming back to your pupil expanders, not expanders. The one which you asked is not expander. Right? You asked for which one, madam? You asked for?
No,
She's asking about the scroll, last scroll. What is the point to?
This last scroll. But because if it's a very small pupil, I think it takes a little more, it's challenging to insert the last scroll. Is there any tips which you would tell to the audience?
Somebody who is really using it can answer.
I have been using it now very regularly. Now my hook use has come down to less than 20%, and is more as the Indian made. As he said, he has not mentioned the name. Please do mention the name. There is nothing against telling the name so that people can buy. It's a Gupta ring, is it not?
Yes, it is Gupta ring, sir.
I use the B hex, which is again an Indian made one, which is working very, very well. As Madam was telling, see, putting it in as Dr. Satyan was telling, less than 4 millimeters only I use it. If it is 4 millimeters or more, you can always stretch the pupil with viscoelastic and do a 5 millimeter 4.5 rexus and then finish up. But if it is less than 4 millimeters, I nowadays put rings for all the cases. I don't want it to come down during surgery. That is my point. A 5 millimeter rexus, 5 millimeter pupil expanded and kept during surgery to retain that will be fine. So that is why I use. And if it is small, stretching, the concept of stretching, what we have been hearing now is different from what she was asking. It is because when you are inserting the last scroll of a ring into a rigid pupil, once the 3 go in, the other part becomes so much stretched away from the last scroll that you have to push this ring very much into the angle to get the last scroll in. So what I do is, initially the manufacturer also recommends do a little bit of stretch so that you get it at least 3.5 millimeters. So on a 3.5 millimeters, if you want to apply a ring, it is easier. And the last, this one, I use a second instrument to hold on to the scroll, and then underneath the scroll, I use a Kuglen's hook to retract and retract both. Retract the iris this way and retract the ring on the other side. So you don't need to go full throttle. You need to do half of it only on one side and half of it on the other side, and then engage the pupillary margin onto the scroll. That will be my way of doing it to reduce the sphincter tears and for the ease of application of this one. And in an IFIS, using a hook, using a ring will keep the pupil dilated, but the protocols which we need to use during an IFIS surgery has to be maintained, because you will get iris prolapse if it is otherwise done. So iris prolapse is not prevented by this dilating rings or hooks, but pupil will remain larger.
I just add one more point to this. Using the intracameral, the pinocaine. Normal dilatation with the tropicamide or tropicamide plus or cyclopamide, whatever you are using, is not good enough. In case if you are not using your pupil dilators, you can use pinocaine. Even if it is 4, it stays at 4, or if it is 5, it stays at 5. So that is the one advantage. You can definitely look at using it, because I often use, even if it is 3, I use, but it stays at 3. It doesn't go to 2 or
it tautens the dilator pupillae and keeps it in that same
pupillary size.
Yes, but Dr. Meenu Martin's things were very important, that those kind of cases to stretch the pupil and manipulate the way he said would be fine. But again, I have one last question. With such a thin pupil expander as we saw now, this Gupta ring, how can it withstand the fluidics of the surgery and stay in place? It will be fine.
Gupta is not thin. Gupta is actually much thicker than the BHEX. BHEX is thin.
Especially if there is a IFS kind of thing. Don't you think in those cases, iris hook would be more ideal? I felt
but
so.
IFIS, multiple IFIS cases I have used BHEX. BHEX will not get loose, or BHEX will not get displaced at all unless you pull on it.
Okay, fine. Anybody in the expert panel to add anything? Yes, doctor.
One additional point, ma'am, just in a uveitic cataract or complicated cataract, I think we should not stretch the pupil to a great extent. We should minimize the stretching as much possible in uveitic cataract, because it can enhance the post-op inflammation.
Okay, right. Yes.
Ma'am, this is Lubna here. I just wanted to add one more point. I've been using Mulligan rings for non-dilating pupils for a very long time. And you asked about the last scroll. So the one tip that I use for myself is, when the last scroll has to be put, I put an iris depositor from the side port and kind of retract the iris slightly backwards, and then with a Sinski just put the scroll in, and it goes very smoothly. And same thing I do when I'm removing. I mean, I'm kind of removing the rings.
Very valid.
Non-traumatic as well.
Yeah, very valid point. Thank you
And
very much.
Madam, I saw him aspirating the cortex after removing the ring. What was the logic in that? Aspirating some bit of cortex after removing the ring. Could you please expand on that? Why would you do that?
Sir, during the phaco surgery, I have not shown in the video, but I found that the bag was a little weak. It was moving around. So I just wanted to put the IOL first and remove the cortex, which was necessary in the center only to, so for the optical axis. Let the peripheral cortex be there. Anyways, it's a uveitic patient. We are going to give oral steroids and topical steroids. And
that is fine that you implant the IOL and then aspirate the rest of the cortex. But I think I saw you removed the ring and then finished the cortex. Was that so?
Yes, sir. I removed the ring, then remove the cortex. It's a bit of my habit to save time actually sometimes, because anyways the viscoelastic is there inside, and the ring has to be removed when the viscoelastic is completely filled in the chamber. And thus to
remove the ring, you need a viscoelastic. There have been a video recently which has shown that in the irrigation also you can remove, but that's okay. Visco is required. But then before removing the ring, I would complete your cortex aspiration, and then one more round of visco injection is also fine.
his logic is that the bag appeared to be a little loose at that point. So he wanted to place the lens and stretch the capsule and then go ahead and remove the cortex.
That's what that I had agreed. I agree to that actually. That is the right way to do. But then after that, he removed the ring also and the pupil became smaller. And then he finished the cortex aspiration. So if we need to fully aspirate, we see better and have the ring on, remove it, then put again viscoelastic and remove the ring and then put again, aspirate again the visco.
Yes, sir.
Just my part of it. So,
Absolutely right, sir.
thank you. Yeah.
Thank you very much. We shall now go on to our next speaker, Dr. Upma Avasthi, who is again a senior consultant working at Sri Madhav Eye and Heart Center. And she is going to show us another interesting case and a lot to learn from that. On to you, Dr. Upma.
Good evening, ma'am. First of all, I'd like to thank you for giving me this opportunity. It's like I'm honored to present in front of all stalwarts. So I definitely seek for some good advices for what I have done, what would I have done better in this case. So just let's start my case, ma'am. So I'll just sharing my screen. Is this visible, ma'am?
No.
You need to click on the share screen button on the Zoom.
Yes, sir, I have done it.
And the pop-up again, the blue button right inside, share.
Yeah, it's share. Yes, done it, but it is sharing open system preferences.
Maybe Mr. Sunil, can you share her video? Yeah, you can carry on.
Yeah. So this was a 70-year-old female patient with the diffuse nebulomacular corneal opacity, and if it can be a little slow down, because I have not read the. In this case, the pupil was very small. It was a dense cataract. The whole it was total cataract. So I have decided for the iris hooks. So in this, I'm placing the iris hooks. The way I have put it is like first go sideways, then rotate the iris hooks under the pupil, and then not that much tighten the first hook. And finally, I have put 3 more hooks to make it a full dilated pupil. And initially, we should be planning for good size rexes because this is a total cataract, not milky one. So it's a full cataract. So that's why I have made a good large rexes. And then a little bit of hydro, not much of hydro because we don't know about the PC status. But now just to clear up all the anterior loosened cortex. But during the sculpting part, what I have seen that there is a little, that zonular weakness is there. So this is just like little slow down video in which we have noticed a small zonular weakness over there. So what I have done, I've little debulked the nucleus by not completing the sculpting part, but then I have chosen to 12 millimeters CTR guided under the rexus margin, and the trailing part was inserted with the help of the Sinsky and the dialer. Because somehow when it is get lost in the angle, so that's why I wanted this to be very much sure whether I have put it in a right plane. Then the phaco was completed. This phaco in the important part was to crack the whole part because it was a hard nucleus, and you can see that this cornea is now giving way. The cornea was actually very poor, and this then the phaco was completed. IOL I have put it by myself, and then it was implanted in a regular fashion. And after that, I have finished the all other part was hardly there was any cortex, so I have removed all iris hooks. There were 3, and again the 3 steps. First is to just release it from the pupillary. First is to just loosen the sleeve, then free it from the pupillary margin, and then bring it out as the curvature of the iris hook. Otherwise, it gets stuck to the side, stuck to the port, and it will be very difficult to remove it. So again, these are in the same way I have removed. And the one important point that I really want to emphasize, I have not made the all ports with full entry. Otherwise, there will be all 4 ports with a large one, and the water keep on leaking. And in this case, I really don't want. I wanted a stable chamber. This is the visco wash, then the hydro of the watertight one was done. And this was the patient did well after the surgery. So pearls from this case, what I have taken that we have to plan for the proper planning should be done. And if we are watching the subtle signs, we should be looking for the subtle signs as well. Otherwise, this case could have been end up with the like Nicholas drop as well. So that CTR would have has helped me a lot in that. Thank you.
Yeah.
Dr. Bharti, are you there? Dr. Bharti, okay. Dr. Nitin?
Yeah.
In this, I think you're driving probably. Now,
Yeah.
in this particular case where there was a subluxation was noticed after the rhexis, would you think probably that we could use iris hooks itself to hold the rhexis margin and then delay using the CTR if it were at least a harder cataract, so that
Madam, there's some issue. I can't hear you.
Okay. Once you come to a clearer area, I will include you in the discussion. Dr. Anybody, Dr. Minu, could you take this? Or
There's
Dr.
some issue. I can't hear you. Can I?
Okay, you can get connected again and then you can
Yeah,
join Dr. Nitin. In this particular case, would you have thought of using the iris hook itself to give support to the capsule and continue it with the surgery, then later place a CTR, or do you believe in using the CTR as soon as you see a area of zonular weakness?
And I have actually understood this. When during a rhexis itself, you can identify whether there is definite zonular weakness, which is very, very sizable. If that is not identified by seeing the folds on the rhexis margin, that means it's not a great zonular dialysis. So when you get the chamber filled up, either with visco or with the fluid, you will see the level difference or the abnormal movement in particular area. If that is there, it was very localized actually when we could see on this one. So I would definitely delay the CTR placement in this kind of a very hard and very dense nucleus, because you don't know where you're putting it, whether it will damage the zonules further. And initially, long back, 10 years back, I used to implant the IOL immediately as the CTR. But nowadays, I realize that it is not needed actually. If you have a capsule hook, it's much better if it can go up till the equator. But even the rhexis zone is better. The rhexis iris hook is enough. But only thing is iris hook sometimes just slips off when the chamber becomes deep. So while performing surgery, you bring down your parameters and don't hyperinflate the anterior chamber like doing in a slow motion phaco in a subluxated cataract. But otherwise, I would have just stopped a little, done a phaco if possible. And if it is too much of a movement, then maybe I will put a CTR at some point of time, but not this early as of now. I would have used iris hooks to support and continue.
Another thing, Dr. Upma, very nicely managed. The other thing is like we should always try to place the iris hook so that one iris hook at least we have near the main incision, so that there was a thick ledge of iris tissue from your main incision. So whenever any instruments is going in, like phaco probe or whatever is going in, it can damage the. So the way Dr. Orting has shown to use it, in a rhomboid fashion, should always try to put
on either side of
iris
the
hooks like that.
Yeah, she can use even 5 because most of them come as 5 in a pack.
Yes.
So
4 were there.
and 1 sub
You could have put one near the main incision, so that would have pulled the iris there.
Actually, I was planning.
Another important thing. I wonder whether you could avoid placing the CTR through the side port and not go through the main port, because once there is zonular weakness, when you go through the main port, there is a shallowing of the anterior chamber and the area of zonular weakness could increase. So if you go through the side port, you showed beautifully using a second instrument to tuck it into the capsular fornices. That's a very important tip. It is just that you did it very well, but you could do the whole thing through the side port unless it's an injector which you're using. The last question.
Injector part, no, madam. I always use it through the paracentesis because, again, the thing is the corneal incision is this long. So when you go, you have to go through the corneal incision up and then come down into the bag. So the direction of implanting it becomes again difficult, and the point becomes more pointed onto the edge of the equator. And the paracentesis, you can always make it opposite to the area of maximum dialysis. And you can implant the first part of the CTR into the area of dialysis. And the last thing you said was to use the Sinski when you are putting it in, you have to tap it down. So rather than using a Sinski, use micro-rhexis forceps to hold the trailing eyelet and hold it and place it into the bag. So you don't have a problem at all. That is much easier.
Yeah.
Oh, good.
For the removal of the iris hooks, what I very often do, sometimes it's a struggle to remove it through a very small incision. So I just remove the silicone sleeve out and just pull out the iris hooks to the main incision. So it becomes much simpler to come out that way.
Oh,
Yeah, that is true. But one thing against that is that this thing is lying outside and it is always moving and it goes underneath the lids and it touches on the exterior part of it and all those. And once you pull that thing also out through the anterior chamber into the main incision and take it out, this external part, rather we could just snip off the external, whatever is lying outside, can snip it off, take out the silicone this thing, and then take out from inside also. That is more easy.
Dr. Kapil, you do a lot of complex cataracts and with small pupil without dilatation. I've seen some magical surgeries which you do. But supposing there was a lot of corneal haze, a little more than was in this particular case, would you consider at this present time of, would you consider doing an optical iridectomy at all? Does it help at all? Is my thought. You have to
Sir,
unmute.
unmute, sir.
Yeah.
Madam, Madam, can I just add a point in this? Like when you have small people and doing the optical iridectomy or the pupil expanders, especially those patients who are having both eyes myotic people, especially those with the rigid myotic people, when we do either the stretch pupilloplasty or the hooks or whatever, once the pupil size becomes slightly bigger than their own earlier pupils, these are the patients who will have a lot of difficulty in reading. Even if you give the near vision glasses, they will never be comfortable. Because I have had two patients, one from the Kuwaiti lady. The sisters had one sister didn't complain much. The other lady almost she took me for a court. The other patient is a VIP patient whom I did both eyes. One eye, the people become the same size. Another eye, the people become a little larger. So he is unable to read with the eye which has little slightly bigger, like a 3.5 mm. The other eye is 1.5 to 2 mm. So these patients, we have to be extremely careful regarding the pupillary sizes.
So what do you do, sir? What do you do then? What can be done?
So far,
I were to do anyway, do cataract surgery. For that, we have to see. But anyway, one thing we can do is do a pinhole pupilloplasty for them. Ask them to come. Let's do a pinhole
that's the only
pupilloplasty.
option. That's the only option we have. But giving them pilocarpine, and he was happy with the pilocarpine. The problem is, he says, I don't want to use the drops. When he goes for the meeting, he says, I don't want to use the drops in one eye, and then it is difficult for me. So he's a voracious reader. He is very happy with one eye, other eye, whatever the power you give, he is able to read, but one eye is 0 and other eye having 1.5 or even 2. He says, I can't tolerate that. So these patients, I'm just saying that you have to be preoperative, you have to do the counseling. And glare, there could be a lot of glare. So that lady almost went in for a depression. She was only 35, 36 years. She went in for a depression. It was a really hell of a problem for us. I mean, of course, she was very genuine in her complaints, but then we should have probably, spoken to her in detail to take up that. So this
Thanks for bringing it up. Very, very good point. We'll remember this.
Thanks for these tips. We shall now go on to very good point. Yeah. We shall now go on to
Can I
our
add
next
something,
speaker.
Chitra?
Yes, Dr. Kapil. Yes.
Okay. So most of such patients have been living with these kind of with this kind of corneal opacity throughout their lives. So even they will appreciate whatever vision they get. And if a simple procedure like optical iridectomy in such cases, in the case of constrict pupil, if they can get even the distant vision somehow, they will manage. Because more, and if you do it in the inferior nasal segment, somehow it helps in reading also. If you get a chance and if that area is clear. So I've done it in a few cases successfully.
Thank you. We shall now go on to our next speaker, Dr. Atul Khadane, who is a senior consultant and director of Yash Eye Hospital. And he's going to show us a challenging case. He is quite an innovative surgeon, comes up with a lot of innovative gadgets. And I look forward to his participation in all our Think Under the Apple Tree programs. So let's see what he's going to show us. You have to unmute yourself, Dr. Atul.
Yeah. Thank you, ma'am. First of all, I'd like to express my sincere thanks. You had given me an opportunity to present in front of such an august audience and these stalwarts. How to share it? I have to take it from the. Is it visible the screen now, ma'am?
You haven't opened that particular folder.
I have opened it. I can see it. Can see. I have opened it, the folder. Then I have to keep it in a separate folder on a desktop first, na? Actually.
Abdul, can you first open your presentation and then do the screen sharing? Abhi ke liye, please stop. Open your presentation and then do the screen sharing.
Okay. First, open the presentation.
Just open your video, pause it, and then do the screen sharing.
Okay, I have opened it. Pause it. Now?
And now you can do the screen share.
Okay, to screen sharing. Share the screen. Share the screen. It's not.
You can share it from your desktop.
Should you probably need some help? Should we go on to the next video while Mr. Sunil, you guide him? He has presented in my earlier webinar. I don't know what problem he is having.
Does Mr. Sunil has his video?
You can play on my behalf. I will.
No, Mr. Sunil, you could show his video instead.
Yeah.
I'm playing now.
Yeah.
Yes, that will be fine. Very much sorry for this. Actually,
that's okay.
Actually, this case is a case of subluxated cataract more than 6 hours. Initially in the OPD, when I saw her, I didn't think that it's more than 6 hours of subluxation. You can see the picture, this is a dilated picture. Well, the first step, I mark the area of subluxation with the help of this. Preferably use high viscosity, that is sodium hyaluronate, to initiate the CCC. You can see the folds on the capsule, the wrinkles on the capsule. That gives an indication that you are going to deal with a bag which is not stable. So aim for a smaller CCC, preferably to be on the side of subluxation, so that you can have put the capsular hooks at that position. The hydrodissection has to be gentle. It should not be popping up the nucleus. The incision made more on a scleral side, so that the capsular hooks can be in a properly position. They will not tented up. Once the hooks are placed at approximately 1 to 2 clock hours away from each other, and then fix the bag. Once the bag is fixed with the help of a capsular hooks, then you can proceed for an phaco. Use in low vacuum setting with a low bottle height. We don't want too much of turbulence. Most of the time, these cases, fortunately in this case, the cataract was not that hard. It's a PSC cataract only. So I'm able to do the phaco with these settings. And just remember, never go the chamber flat before you remove your phaco probe. Fill the AC from with the visco. Even then, after putting in IA probes from the bimanual, aspirate the remaining cortex. The bag is fixed with the help. Up till now, the bag is held up with the help of the capsular hooks. Before removing the irrigation probe, again fill the chamber with the visco. Keep the bag taut so that there should not be chamber should not go flat. Then I use an CTR ring. Try to insert from an area where the zonals are attached and rotate it. And before you finally place the CTR in the bag, see to it that the two eyelets of the ring should be in the area, preferably away from the area of an subluxation. Since this was a case, I removed the capsular hooks after putting in CTR. Maybe I thought this was a mistake from my side. I think before putting CTR, I should have removed the CTR, the hooks. Maybe sometimes the CTR will entangled in the capsular hooks. Maybe sometimes. It was a toric plan case because she had a corneal cylinder of something around 1.75. It's an Indian hydrophilic IOL. Once I put it in the bag, the bag seems to be quite stable. Everything was going in a proper way. I was happy that I had managed the case properly, and the things were as if planned. The lens was put in an axis, which is designed that is 110 was something like that. I will marking the place where I has to place the IOL. And after putting on everything and confirming when I removed the visco finally and about to do the hydration of the ports, the everything seems perfect. I was about to just finish the case. As soon as I remove my irrigation probe, I see that the bag is not stable. The lens is coming out. The bag is subluxating on one side. So you can see here that the whole things are coming. So I decided at this stage to fix the bag with the help of an CTS segment. 10-0, it was in Gupta segment. A little more incision size is required to pass on that perpendicular part of the segment, because not possible to negotiate it to the 2.6 or 2.8 incision. So I'm slightly enlarge it, then create a space. In 26 number needle is inserted through the Hoffman packet. I create a Hoffman packet there. The step is not shown here, but it's an Hoffman packet I create. The tenoprolene then taken out. A little bit of mess. The iris was coming out from the main incision, but I'm trying to manage it by putting it again inside. Then after the CTS segment is threaded with the tenoprolene. The segment is, then I'm trying to negotiate and place it properly in a place where there is an area of subluxation. Then again 26 number needle from the same site, and the second arm of the tenoprolene needle taken out. Now I am positioning the CTS segment, the perpendicular part above the CCC, and the circular horizontal part goes in the bag. Once it is confirmed, the picture is not that clear here because of the iris pigment release and little bit of mess there. Now I am taking out those two tenoprolene threads out of that Hoffman packet, cut out the needles there, and then after that some 4-5 knots, because there is a chance that this tenoprolene knots can get slip. So it's like 4:3:2, something in that fashion. I tighten it, and once the thing is almost fixed, the threads are cut close to the knot, and you can see because of the Hoffman pocket, the knot goes inside. So the irritation part afterwards will not be an issue. And now the case is almost finished. I take a suture at the incision because the iris was popping out many times. So I thought it's better to be sutured, because little bit large incision I think I had made in the file, so that the CTS segment should go properly. And then I remove the visco with an bimanual, and the case is finished. Most of the patient is initially 2-3 days. It was there was some iritis component and some stromal folds, but at the first follow-up on the second follow-up on 7th day, the patient was very happy. Thank you.
Wonderful, wonderful video, Dr. Atul. Very, very nicely shown, and a lot of teaching which came in, especially that point which you said that the CTR, it's very important. Every tip you gave during the surgery was very useful, including that the CTR eyelet should not be in the area of the zonular dialysis, but it should be away from it should be kept at when intact dialysis. Dr. Ajay, are you there? Dr. Ajay? He was there all along. Okay, we missed out.
Can I make a point? Can I make a point, Chitra?
Yes, yes, Dr. Nikhil.
That was a very well done surgery, absolutely, in spite of all the difficulties. A few points which I would do slightly different is in these cases where rhexis is very difficult, it's very important that once you initiate the rhexis, you support the rhexis with a Krugen's hook or something, something to support the rhexis. And once you've got a little bit of a tear, it is the right idea at that stage itself to put in your capsular hook, so that the capsular hooks act with a counter pressure, sort of a counter traction for the rhexis, and the rhexis becomes much easier. And I would do this rhexis with a micro rhexis forceps after initiating, because then it's more simpler to do it, especially with the counter traction. The other point is, instead of using the 10-0 Proline, I would, today Gore-Tex is available. I think it's a much better idea to use a 10-0 Gore-Tex instead of 10-0 Proline because of the biodegradability of the Proline. Otherwise, a fantastically done surgery.
Yes. What kind of dialysis would we not use a premium IOL? Dr. Meenu? Can you unmute yourself?
First of all, this was done quite very well and fantastically. Congratulations, Dr. Atul. And the point is, the first thing I would have done, I will answer to your question, madam. The first thing, one or two points I would like to say. First thing is, to begin with, I would put viscoat or a dispersive viscoelastic at the area of solid dialysis to support the anterior vitreous space there, so that you don't aspirate off the vitreous at some point of time. And that also helps you to identify how much of dialysis is there, which you cannot identify unless you retract the iris. So you had mentioned younger patient with more than 6 clock hours. So younger patient with more than 6 clock hours of dialysis, I would plan to fixate the bag before itself.
Right from the beginning.
Right from the beginning. So I would, you can even put in this segment CTS and then hook it with an iris hook and keep it there, rather than having multiple iris capsule hooks. So that itself can be sutured later on after taking out the whole thing. And the other thing is I would hydrate all the parasites and the main incision before taking out the visco itself. That could have avoided this forward movement of the bag. So we know that 6 clock hours is off zone use. So even if CTR is there, if you shallow the chamber, it's going to come up like this. That's for sure. So if before the chamber is emptied of the viscoelastic, I would hydrate everything and not let this happen. Maybe even you can put pilocarpine also. But that is the point where you got the awareness that it has to be fixed. So that's fine. And I would not promise a toric IOL or a multifocal IOL in this kind of patient, especially because it is more than 6 clock hours. So you can tell that I may be able to place, but at some point of time, it may not be possible also, which I will be in multifocals. Definitely I would not, but torics, if the bag is well fixated, the toric will stay in place. That is what I feel. And usually it's a hydrophilic lens. It looked like a hydrophobic lens.
No, it's a biotech lens, biotech toric.
Which is hydrophilic or?
No, hydrophobic. It's a hydrophobic.
You said hydrophilic. Okay, but so hydrophilic phobic will be the best.
Actually,
he has enlarged. No, Dr. Atul, you enlarged the incision a little. That could have also altered the SIA and some kind of the calculation error which could have trickled in when you are inserting a segment. But I suppose inserting a segment was something which was not in the plan initially.
Actually, I thought initially it's a 4 clock hours subluxation. I can manage with CTR. In the initial picture also it looks small. Even when to start the case it looks small, but I misjudged it in the beginning only. Then I realized that it is not. It's more than 6 clock hours. I have to fix it.
There is another company, CTS, which is much smaller and goes in through a smaller. I would like to name Orolab as the one which I use is from Orolab. This eyelet is not such a huge one which stands out like such a big one. It's not it just raised up and it is very flat. So it
from Madhu, actually, I had that in my armamentarium only that day. That's one. But somebody already suggested me this, that Orolab had a much thinner one.
Yeah, and the Gore-Tex part, I definitely agree. Gore-Tex would be my first choice, and it's not. I think it comes as 7/0 Gore-Tex rather than 10/0 Gore-Tex.
Yeah, 7/0.
Yeah. Anything, Harshul, you want to add anything before we go on to our next speaker?
Oh, I think this was a wonderfully done surgery, Dr. Atul, and congratulations. And I think all the points are very well covered by Dr. Meenu, Dr. Nitin, everybody. Wonderful.
We shall now go on to our next speaker, Dr. Vinita Ramnani, who is a senior consultant at Bansal Hospital, Bhopal. And again, a very important person from Madhya Pradesh, and very well known and a great friend to all of us. And again, a very capable surgeon too. So let's hear what she's going to tell us. A lot of pearls will come from her presentation.
Thank you so much, ma'am. Thank you for giving me this opportunity. I am very happy to share my views. Let me share. Give me 1 minute.
Mr. Sunil, maybe we could share her video too.
And I have presented in a lot of videos, but I don't know why I am not able to share.
Okay, that's okay. It's not. It's
okay. Okay. So thank you, ma'am. Listening to all these wonderful videos, now I'll come to demonstrate the cataract in a pars plana vitrectomy. There are a lot of complications when we do a surgery post vitrectomy patients, because there is no vitreous support and sometimes there is an oil or something inside. They have very deep anterior chambers, zonules are very weak. So doing a surgery in such patients is really difficult, and many of the time you can have the silicone oil into the anterior chamber, the poor quality of endothelium, and many other complications which are pertinent to the previous surgery, and maybe a very dense, thick cataract with dense plaque, most so in the posterior part, and non-dilating pupil, compromised zonules. So you have to prepare yourself, your mind, individually looking into the each and every aspect of doing such surgeries. And most of the time you require a periorbital anesthesia rather than topical. So if you do a capsular access, probably you may come across the capsule like this. So you should be prepared enough to cut this thick capsule and proceed further. So this was like very well cut round this capsule. After that, the capsular axis, you can do an hydrodissection, hydrodelineation, depending upon the case, but then it should be multi-point. It should not be very vigorous. It should be very slow, because we might have weaker zonules and we can exaggerate our zonular weakness in this. And when you do a phaco, it is better to use a Kilman phaco tip and do a lateral separation and chop to avoid the zonular dehiscence. So this is the patient where the pupil was not dilating fully, though the cataract is mature, but then it is not very dense nuclear cataract. We can easily manage without doing any hooks or any other manuring, but it has to be very gentle. Be careful about the bottle height, and then you can adjust according to the amount of the fluid entry you require into the chamber while you are doing a phacoemulsification. Also, the phacoemulsification has to be very gentle, otherwise there could be a possibility of PCR at this stage, because the pupil is even getting down, and you can manage with slow and sturdy nuclear aspiration. So once you have done this, I think you are okay. But in one of my case, you can see there is a very dense, sticky cortical matter over the PC, which was very difficult. I was very worried about doing an IA in such patient. I was thinking to pierce. So I started doing it with a Simcoe gently, and it came out. In one of my patients, they are all different patients. It is not a single surgery. In one of my patients, there was such a thick, dense plaque which is sitting there on the posterior capsule that we expect as the posterior segment surgery is being already done. Even there is a little bit of PCR at the side also, but then I just wanted to clear up the posterior capsule. This is another patient where the posterior segment glow was not good because of the previous surgery. So all videos are from the different patients. I just wanted to express that if you have different kind of a problem at different sittings, you can have these. And one of the biggest problem is misdirection of the fluid. So you have to be careful, and post-operatively the complications can be more. So you can prepare yourself for dealing with these complications. Thank you so much.
Thank you. That was a wonderful compilation of the challenges which you can see in a post-vitrectomized eye. But one important thing is, in a post-vitrectomized eye, I think it's very important for us to do an AIOS and rule out, identify a PC touch if we can. That is one important thing which is there. The other thing is, I think even in these eyes, you could anticipate something like a reverse pupillary block, which can occur in high myopic eyes. So it makes sense to make a shorter tunnel and use that spatula to lift up the iris if you get that kind of a fluid misdirection. I'm adding to your points. The other thing is, if you have a plaque in these eyes, do you think these are eyes where the posterior capsule can give way, or that plaque would be actually be a support itself because it's fibrosed? The posterior capsule may not give way easily in that. I don't know. I wanted to ask that question to you all. Dr. Meenu?
It's not that these plaques will give way. Plaques are because of either they have touched it but not broken the capsule, or this long-standing silicone oil can also induce this. So if it is coming in the visual axis, I will always open it up and place the IOL. Otherwise, if it is outside the visual axis, beyond 3 millimeters, I just leave them. They don't. And the point Madam showed about the cortex is very, very common. There are two types of PC cortex behavior. One thing is long-time silicone oil, it just comes off just like that. Once you aspirate, you don't see any cortex. All cortex is so polished. The other thing is you will see like Elschnick's pulse. It will be like one layer of thick Elschnick's pulse sitting on the capsule. So you'll have to irrigate and shave off this from the PC and go on till the equator in all clock hours. So it doesn't come off from one clock hour if you do, next time doesn't come. So you have to keep on aspirating, and then you will see fibrosis. Sometimes it's fibrosis over the capsule. So if you're able to identify one area of plane of cleavage, you can sometimes peel it off from the visual axis. Sometimes it's the whole capsule which is thickened, that you cannot do much about it. We can always do a rhexis around it if it is possible, or we can even cut with your scissors or your thing, so it will remain very, very firm if it is within the large 5 millimeter kind of big plaques. But many white-looking capsules, fibrosis, do not affect vision much. So we may think on the table it's looking very white, but post-operatively, although it looks white, no patient doesn't appreciate. They will have some contrast loss, but otherwise the visual acuity-wise, they don't. It is not so less. So need not very adventurously pull off all these thin-looking white capsular fibrosis which you see in the center.
Just to add a small point that when you have very thick ones in the visual axis, sometimes what we do is we cut it with the scissors, and then you can use a vitrectomy cutter. So we can make it a nice small opening in the pupillary axis. That will be really nice.
And if you are using an immersion biometry, you should remember to change the velocity because of silicone oil filled eyes. That's one more pearl you should say. And the other question I'm going to ask Dr. Satyan is, if it were a case of a macular traction detachment and all that, or the fovea is displaced, in those cases, even with optical biometers, you may not be able to accurately measure the axial length. Does it make sense to place IOL, as a secondary procedure? Normally we will not think of that. I just thought that that's also one thing.
Even if you are going to plan in a complicated position as a secondary IOL, then even then, I don't think you have a proper measurement of the IOL powers.
Yes.
We did it one today, just today afternoon I did one.
Yes,
so if it is an RD or definite more than 1 millimeter, if it is off the macula, I would not measure it. It would not measure properly. But in aphakic mode, actually, if you do optical measurement, I think you should be getting. What is wrong in getting aphakic mode? If you do optical, how will it go wrong?
No. I'm not saying about the
optical biometers that
I'm talking about the IOL power, exact power. That's what I'm trying to
Calculation will go wrong because the fovea is not in its place, it's displaced.
No, I am talking about when you, before you do a vitrectomy surgery, when you do combined surgeries, that is when I leave it aphakic. And after the vitrectomy surgery and the flattening of the macula, then when you go in for either silicone oil removal or a secondary IOL calculation, secondary IOL placement, you can get a correct measurement by the proper position of the macula has been regained. That is where you place it.
That's absolutely right. That is not, that's not I'm talking about. When it is like that itself, I'm talking about.
Madam, as such, each patient has a poor visual acuity, and then a lot of posterior segment pathology affects the refractive outcome. So again, doing one more surgery for these patients, already they have undergone a vitrectomy, so or maybe a silicone oil removal. So the best idea is to do with little bit of refractive surprises, probably.
Nowadays, please don't underestimate VR surgeons. They are doing very great work and they get very good. Previously, we used to say vision will not whatever, but nowadays it is giving very, very good visions nowadays. You can't imagine how this has improved. It has improved drastically. They're getting, many people are getting very good vision.
But anyway, having said that, premium IOLs definitely, maybe you could think of an eye-hands IOL in these cases, but not the other IOLs, right, Dr. Satyan?
I wouldn't go, madam. I wouldn't go for any of these multifocals or trifocals or whatever you call it as. But eye-hands to an extent, okay, but then still you won't get that whatever the
because that you can't promise anything at all. We shall now go on to thanks a lot, Dr.
Thank you, madam. Thank you.
Yeah. So we shall now go on to our next speaker, Professor Dr. Sharmana Bhava, who's a professor of ophthalmology at VMKV Medical College, Salem, and he's going to be showing us another very interesting case. On to you, doctor.
Very good evening to all, and I personally thank you for the opportunity. As all of us are aware of, managing aphakia would be a real challenge, and more so the challenge is doubled once you are also dealing with a fixed pupil, which is an enlarged and a mydriatic pupil, as in case of trauma, wherein the sphincters are blown out. We start with the case of this, wherein you do a limited anterior vitrectomy and you proceed with the case. Herein, I'm using the tenoprolene on my right side, and that has gone into the AC, and a side port is created through the MST forceps. I'm just lifting one of the leaves of the iris and making engaging that into the needle. Through the other side, through the same port, I'm going through this 27 gauge needle, railroading this 29 gauge prolene, tenoprolene into this 27 gauge needle and bringing it out to the left side. Once the needle is retrieved out, as shown here, entirely, you should make sure that the needle is bent as shown here. Also, the needle has to be entirely retrieved out with the suture on. You pull it to an adequate length. And once that is achieved, you go through the anterior chamber and you create one small knuckle of those suture, a loop of it, and retrieve it through the same MST forceps. Now is the time to create a single pass 4-throw pupilloplasty. It is very well demonstrated in this video, the 4 throws, which has to pass through the loop, and that is to be ensured. Once that is done, you need to just pull the 2 ends of the sutures apart. Now you have a self-retaining knot inside the AC. Now go into the AC and trim off the edges of the knot. You're done with one of the pupillary management. The similar thing is done on the other side. This is essentially done as shown here in the 6 and 12 o'clock position. And you create the similar single pass 4-throw pupilloplasty on the other side. And that is completed. Now you achieve a fairly round pupil. Now you manage the pupil. Now comes the challenge of managing the aphakia, for which 5.5 millimeter main incision wound is created, and diagonally opposite 180-degree paracentesis is done. That is to achieve the fixation of the iris claw at the 180 degrees. Now the iris claw is propelled with the iris claw holder. One side is enclaved with the rod as shown here. Again, you do the same thing on the other side. And also assure that the knuckles are formed, iris knuckle, and the iris is properly fixed. This is the end of the procedure with the very well-centered IOL and also the round pupil and the pupillary margin also covering the iris claw lens. Now you do the irrigation aspiration and remove all the visco and hydrate all the wounds, side port and the main port. If necessary, you can even put the suture on the main port. Ensure that the AC is well formed because it's already in aphakic eye. Once that is done, you close the conjunctiva by the cautery. Then either you give the intracameral moxifloxacin or subconjunctival antibiotic, steroid, and the case is over. I also thank Dr. Jaiprakash for assisting me on this video. I would take up any questions. Thank you, madam.
Thank you very much, Dr. Sharman. That was a nice, very good teaching video which you showed here for us. One question is, do you really feel that by taking a bite through the 26 gauge needle, you could actually cut through rather than using a Prolin needle to pass through the iris and just keeping this 26 gauge needle in place for the passage of the needle? Dr. Meenu, would you have any thought on that?
Yeah, I exactly wanted to tell that. Nowadays I have shifted to that because there's no harm driving it through, but in all irises are not like this. Many are distorted, they're fibrotic, they're thin, yes, and they're loose. And sometimes you get this 27 gauge needle cutting in through that, it becomes a large opening. And when you make knots, it tears through. So I nowadays sometimes use the needle just to touch the iris there and then push the needle through it, or even just hold the iris margin and pull it around, and then make a sharp nip. So the tip of the Prolin needle has to be well maintained. That's the problem. Don't touch anywhere this needle. When you're putting in also, open up the paracentesis properly and don't take it through a direct corneal entry. Make a small paracentesis and identify the plane and take it in so that you don't damage the tip. Then it will pierce the iris much easier. And that is taken in. And one more last thing is not to fill up the chamber so much when you are irrigating, aspirating after putting this iris sutures. Sometimes they give way. So if you inflate it too much, so to give it, do it through a little open wound and aspirate it with the lower bottle.
Madam, that was just to prevent two entry of the needles, and railroading was one of the steps to overcome that. Nowadays, we even do with the AC maintainer, and wherein which the visco and management and the deep chambers, other complications.
Actually, Dr. Amar suggests fluid in the chamber for this pupilloplastic forethrow.
Yes.
The other question, Dr. Satyan, do you use iris clip lenses?
Yes, I do use it.
So can you tell us how you would, just for the delegates to know, how would you calculate the IOL, do the IOL path calculation when you're planning to use an iris clip suddenly on the table?
Basically, it is the A constant, which is completely different from all other lenses. It is 1 and 7.5. So you have to be very careful when you're calculating the A constant. So it is the only thing. Otherwise, it is same. It is quite easy to do it than all other type of lenses. I feel it is very comfortable for me to do that. Only thing is when you get older, like 40s and 50s, you have essential tremors. So only those times you will find it little difficult to enclavation is little difficult, especially when you have your right-hander. When you're enclaving with your left hand, you feel your tremors is more, your enclavation becomes difficult. I'm just giving a very practical tip which I go through.
Sometimes it is easier to enclave with the tremor. No, just keep it there. It will shake like this at the enclave. Somebody was telling some live long back. I remember somewhere They were telling vitrectomy, see, my hand is shaking, but see, I am easily able to do vitrectomy with this assistance of this tremor. And he was telling himself. So, but then could you please tell me which forceps do you use to hold the iris claw lens? Which company do you?
I bought it almost 7-8 years back. There was one which is very flat, both the top and bottom is little round.
That is what. That is what.
And another
MST or where did you get it from? Because nowadays good ones are not available now.
Yeah, it is quite uncomfortable, especially when you are having essential tremors to hold it in your left hand when you are implementing it in the right. Then it becomes really difficult because I used to find it difficult. But once you take the tablet for your essential tremors, then you become more comfortable. And just a very practical tip. So I think it will be very useful for many people, especially those with above 40, 50 years.
Hello, sir. Sarvana, sir, do you suggest any forceps? Which one do you use?
Sir. The ones which we regularly use is Hansraj, and also Apasami also manufactures the same, sir. Nowadays, we have a variety of designs. Almost all the surgicals, they are making it. Only thing you should buy the ones which are having a thing like that, some indicator so that the claw is shown there. So those are little better so that you know that the iris holding forceps is there and this side is the claw. So the entry. So that also will be a clue for assisting the inflammation.
Okay.
I just had a question. Does anyone have an experience with Nivian's scleral fixated lens? Because that Dr. Nivian's scleral fixated lens.
CMT Flex.
That's right.
No experience as of now.
I have no experience, but I'm sure it must be definitely one very good way to go. The other question which I have with Dr. Meenu, you use SFI, you also use iris clip also. So when would you use what? What makes you decide which kind of case you would use? Secondary aphasia, you would use oil and
no iris claw. Nothing, 100% nothing against iris claw lenses. But I do only glued AIOS.
Okay, right. And what would be?
I'll just add one point to that is when you have a very large pupil or iris is torn and you have a very large iridotomy done, those eyes, you have to shift the position, or those with a very large pupil size, like a traumatic mydriasis, then iris claw is not the best choice. You can go with
if you do a pupilloplasty, you can use it.
Yeah.
And post-op medications, Dr. Satyen, what would you advise? How long would you like to keep them on anti-inflammatory and anything? Pigment dispersion is hardly there.
PI?
Yes.
We have done a good vitrectomy. PI is an option.
Yes. Initially, the problem is once we have done a proper vitrectomy, PI may not be really required. But once we have not done a vitrectomy, those with the younger ones where they were anti-vitreous space is intact, and if you don't do a PI, you will be in trouble. So just make sure if you have not done a vitrectomy, make sure that you do the PI. That is a must. So for the post-op management, I go for a month normally. Otherwise, normal IOLs, we just give it for 2 weeks max, or 3 weeks is the maximum time we give. But probably just a month or 40 days is fair.
Yes. I'll now go on to our next speaker, Dr. Prema Upadhyay. Are you there?
Yes, madam.
She's a medical director in Seva Saran Eye Hospital, Bhopal. And let's see her interesting video. On to you.
Good evening, everyone. I would like to thank Chitra madam and the team ARC for giving me this opportunity. I am sharing. My screen is visible, madam?
Yes.
Yes. I am sharing cataract surgery after penetrating keratoplasty videos. This is cataract after post PK. Main tips which I want to give, one should protect the endothelium because we want to protect we want to prevent graft rejection after surgery. That is the utmost importance. So in these cases, we are using soft shell technique using both cohesive and dispersive viscoelastic to coat the endothelium. Second important thing is that all the port should be away from the graft host junction to prevent injury, and that should be at the steepest meridian to reduce the astigmatism. And all the instruments should be kept below the iris planes. So again, all the maneuvers we are doing to protect the endothelium, and these bimanual irrigation aspiration I am doing. Here I am using single piece hydrophilic acrylic lenses. So choice of IOL depends upon the case as well as surgeon's choice. Usually we use less chromatic aberration lenses, aspheric lenses in these situations, and try to, this is another case in which astigmatism is very high, about 8 diopters, and therefore I am planned to use customized toric IOL in this case, and here markings is required only at 0 to 180 degree. Cataract is of grade 2-3. I am making rexis here with the Utrata forceps, and main thing is that whatever means you do, AC should be well maintained, and keep all the parameters at low levels so we avoid turbulence in the anterior chamber. And here I'm using a stop and chop technique. After making this trench, I'm dividing and using blunt tip chopper. Avoid to use sharp choppers or in these cases if there are synechias, because every case is different after PK. And the main challenge is not only to protect endothelium and graft host junction, as well as if there are synechias or if there is distortion of anterior segment anatomy, you should take care of that also. Here I am using this plate haptic design toric IOL. This is a customized one, and this go with the normal injector, and a 2.8 millimeter incision is required. Main thing is that there is no need to do rotation. It should be placed at 0 to 180 degree only, and it usually gives good results. In this case, residual astigmatism is only 0.5 diopter, and you have to give send all the parameters like anterior chamber depth and axial length and K readings to the manufacturer, and these are very good lenses for post-PK, post-RK surgery, or sometimes even corneal scars after pterygium. So my experience of using these lenses is very good, but every case is not the same. Like here, I have planned a single piece, but media is quite hazy. Although endothelial cell count is good, but there are big suture marks because it is almost long. I have done PK long back. So here I have planned to put 3-piece IOL because I'm not sure about the zonules, and put one suture also because eye is myopic. And do not overhydrate the side port and main port, because again there are chances of giving up the wound.
Yeah.
So these are the few tips we should take care of before planning post-PK cataract surgery. Thank you.
Thank you. I just wanted, is Dr. Kanika Bharadwaj there? Dr. Kanika?
Yes, ma'am, I'm here.
Yeah, so you will be the next person to go. I'm very sorry. It slipped my mind. I didn't call you earlier on. I have a, who's anybody is in the cornea in this particular group? Corneal surgeon, even the speakers, you all could add. I was searching for Dr. Nivedita. I think she has left, because this question which I have is, when would you do a combined surgery and when would you do only keratoplasty?
Madam, it depends upon the case. Actually, sequential surgery is better, particularly younger patient, because main problem is in biometric calculation. IOL power calculation is better after removing all the sutures and wait till the astigmatism get stabilized after 3 months or 4 months. So sequential surgery is better, but sometimes cataract is so dense, and sometimes patient is one-eyed. You have to give them visual rehabilitation in elderly patients. So in these situations, we do combined surgeries. But definitely, what I feel in the studies, in most of the studies, it is proof that there is not much difference. But still, definitely, there is a difference in biometric calculation because after the stabilization of astigmatism, these anterior chamber depth, K readings, and everything get stabilized. So power calculation is better.
Now, toric IOL, you understand that toric IOL, there is a debulking of astigmatism because astigmatism is huge in these post-keratoplasty eyes. But if it is an irregular astigmatism, I don't know how a toric IOL can be planned, number one. Number two is, supposing some of these eyes have a need of a repeat keratoplasty, then the toric IOL will have to be removed, no? So,
Madam, actually nowadays after rejection, usually we are doing endothelial keratoplasty. So usually there is no need to remove actually toric IOLs. And there are many studies in which people are using toric IOL after PK as well as after keratoconus also these days. And usually patient remains very happy because they are very needy patients, madam, and usually results with these
magnitude comes down
customized they feel happy. Because
that's one point which I wanted to, sorry, continue, madam.
Patients are happy with their contact lenses, no, they will not be happy because
all the patients are patients, madam, won't ready to use contact lenses unless patient is young and a little bit educated. Usually they are villagers and come from very difficult for them to use contact
in the city. We need to be thinking because there are patients who are getting good vision with RGB rose K lenses.
Definitely, madam,
and
definitely.
In those cases, placing a toric IOL is not the solution, I think. Yes, Dr.
One small point is she had mentioned she puts the incision on the steepest axis for the astigmatism. What I do is I always go temporal only because these are difficult ones to do. Visualization is difficult. So I will be in my most comfortable location and forget about the small time astigmatism, which you will correct with your small incision because the original astigmatism will be terrible and huge, which you need to correct it in a different way. And some of them come with very hard black nucleus, and I don't do phaco in them. I do a scleral tunnel and an SICS, and if needed, suture also the incisions. We need to basically, as you are repeatedly telling, protect the endothelium and retain the graft clear. So, choice of surgery, type of surgery itself is according to the patient or the surgeon's comfort level. If SICS is also done as effectively as they can do phaco, I would do SICs in these kind of very hard black cataracts in this one. And even suture also.
100% agree with you, sir. It depends upon the type of the cataract actually. And sometimes we do SICS. It is not always phaco. But here the cataracts are relatively soft. So that's why I have planned.
Yeah, we shall, thank you very much. We shall go on to our next speaker, Dr. Kanika Bardwan, who's stepping in on behalf of Dr. Ritika Sachdev, who's got missed flight got delayed and she couldn't take the flight. And very nice of you, Dr. Kanika, to step in, and we look forward to your presenting your video and the discussions which will follow. It's a very interesting case again. On to you.
I'm actually honored to be doing this on behalf of Dr. Ritika ma'am. She's unfortunately not available for this. I would like to present a surgical video on ma'am's behalf. Just give me 1 minute. I'll be sharing my screen. Is this visible, ma'am?
Yes, yes.
Okay, so as cataract surgeons, most of us, we are happy if the vision is 6/8 part, 6/9, and we're like, okay, this is done, and we are settled. But quantity of vision is not the only thing that the patient is concerned about. This is one such unhappy patient who had a good vision post-op, but still was not happy. And the patient was operated elsewhere in Nepal, like 3 years ago. And there was a clouding of vision. The specific complaint was that the vision is cloudy. He was not complaining about the reduction in his vision. So when we noticed that there was already an IOL in place, which was a little bit opacified. So we went ahead and planned a secondary IOL procedure for the patient. We released the adhesions from the anterior capsular rim, as we can see here, a beautiful capsular axis we can see. And once the adhesions were released, we tried to remove the intraocular lens from the bag So this is the same process being done. We can see some cortical fibers that must have been left in place during the first surgery, although the visual axis looked clear. So now we are trying to pull out the IOL optic from the bag, but as we can see, it's causing a lot of strain on the zonular complex. So what we instead think of doing at this stage is that instead of bringing the lens out as a whole, why not just dial it and cut it into pieces and then bring it out, so that we impart less stress on the zonular complex. So we cut the first haptic and then we take the haptic out. This is the other end. Now, when we noticed that the bag was not very good and it was not supporting well and it was decentered, we do put a capsular hook here. Notice the angulated hook, it's not like an iris hook. And once the bag is supported well, we again resume the process. We take 2 instruments, try to rotate the lens, bring it out. Again, a lot of copious viscoelastic is used so that the stress is lessened as much as possible. We are then using a smile forceps to manipulate the optic of the lens. We cut the second haptic. So now the lens has been divided into pieces and we bring it to the chamber. Once the IOL is in the chamber, it is then again cut into 2 separate halves so that it can be explanted easily with the help of vanas. A lot of viscoelastic going in. We grasp it with the smile forceps and it's out. So this way we kind of salvage our bag and the lens is out. We then plan another secondary IOL with a clearer platform. This is the foldable 3-piece lens. Now, even though the bag was there, we decided not to go ahead and put the lens in the bag and instead put it in the sulcus. We have a very good rim and bag support, but the bag may not be of a good quality, and of course, it might not support the lens. So we place it in the sulcus, we clear up the chamber, and we can see that the rhexis margin is still intersecting the pupillary plane. So what we do is go behind the lens and just make a nick in the anterior rhexis margin so that the bag is a little bit loosened and the pupillary axis is clear. So at the end of the procedure, we can see that the visual axis is clear, and this is the explanted IOL, which shows vacuolations in the lens capsule, a magnified view of the same. The patient, after the surgery on 1 day post-op, was around 6'12", but happy. He said that yes, he can appreciate the difference in contrast that this has brought to him. And at 1 week post-op, he was 6'6" with a 0.5 cylinder and very happy. He said his world looks brighter now. So take-home message in this case is that many a times when patients come to our clinic, we just brand them as unsatisfactory patients or not happy patients, but then we do have to take into account what the patient is trying to say to you. And this patient particularly came to us with not reduction in his vision, but he said, I can feel there is a cloudiness that has come to my vision and it was not before. So we paid heed to the patient. Of course, we have seen many people just say, no, your vision will get better. You're 6'6", you're 6'9". Why do you want to go for another destructive procedure that can cause some anatomical distortion to your eye? But here in this case, with a good planning and surgical management, we were able to make the patient happy. Thank you so much.
Yeah, we have 4 of you expert panel. I would want to ask you all one thing. In a situation where she has managed it very well, a very good case, no doubt. But if there is a zonular weakness, would any of you all consider placing a 3-piece IOL in the sulcus and doing in the bag and doing an reverse optic capture?
Shall I?
Yes.
Yeah. So the thing is, first of all, this is a hydrophobic. I think it's a hydrophobic IOL. So the edges or the tips of the bulbous tips of the haptics are the ones which get mostly fibrous and adherent at the equator rather than the optic. So the optic doesn't have much of an adhesion. You can easily separate it. So visualization of the edge of tip of the haptic is very important before we try to dial like this. So that is what I do. And if we pull drastically like this, it's going to pull the bag and it will cause zonal dialysis. So if you cutting the haptic is a great idea, which we commonly nowadays do, so that the direction of pull can be changed. The whole unit, when it moves in one direction, you cannot direct the haptic to move in different directions. Still, if it is pulling on this one, it is better to cut it and leave it there. It stays inside the bag, no issue. But in this case, when we had seen that one part of the rhexis margin has become flat, it just not just like that happen. It will happen only if there is a zonal dialysis, and definitely there is a zonal dialysis there. And ideally, we should put iris retractor. I would have put iris retractor hooks, identified that area which has a zonal dialysis. If possible, put a capsular tension ring and identify Sommer's rings and after cataract. That I don't consider that as a leftover cortex. It looks like after cataract, which is part of Sommer's rings. And if we leave some of it after removing some of it, the others will get, especially from superior, will get hydrated and start falling into the visual axis later. So again, visualization of the equator, looking for these kind of Sommer's rings and the periphery, and evacuating the bag completely is very, very essential. And filling up the bag with cohesive viscoelastic. And if necessary, in this case, I would have put a capsular tension ring to get the rhexis rounder, and then either put a single piece in the bag or put a 3-piece in the sulcus and optic capture, if that is possible. But optic capturing in this kind of very fibrous rims is slightly difficult because it doesn't stretch so much. But this was like a slightly larger, around 5 millimeter rhexis margin. We could have given an attempt on this. And while capturing also, don't capture the dialysis area last, because if you capture the dialysis area last, you'll have to stretch a lot onto the opposite side and you'll cause more dialysis. So I would have definitely not cut the rhexis margin.
Optic capture also doing will be difficult because she has cut the anterior.
That is not possible. After cutting it is not possible. But I would not have cut it to get it away from the visual axis, because it's going to fall further down by contracture later on, if the dialysis is still there. So I would have addressed the dialysis and then try to center the lens in one of these ways.
And a CTR was absolutely necessary to have been placed where once you notice the zonular weakness. And of course, clearing up the capsular fornices is also extremely important. Dr. Satya and Dr.
I have ruptured capsules. I have ruptured posterior capsule by trying to pull like this. If it pulls towards one side drastically, it may split the posterior capsule also sometimes, other than the dialysis, which also can happen.
Yeah. Anything to add before we go on to the next case? Dr. Satyan, Dr. Nitin, Dr.
Chitra,
yes.
May I add something to this?
Yes, yes.
The management actually depends upon the type of IOL which has become opaque, right?
Yes.
If it is a hydrophilic, which were frequently becoming opaque, it's very easy to take them out. Depends upon the structure or the make of the IOL also. Those C loops one were very difficult to take out because of the adhesions at the fornix. So the best thing is to cut them with the first intention. You have to cut them, not to take them out. You cut them at optic haptic junction, place a CTR wherever you exchange, and place another lens in the optics, right? And the hydrophobic ones or the lenses with 4-point support systems, they are very easy to take out because the area which is adherent is very less, and most of the time you can manipulate them out of the bag and you can place another IOL. So this is what I want to add is depends upon the make of the IOL.
Thank you very much. We go on to our next speaker, Dr. Aishwarya, who's a senior consultant cataract and refractive surgery from Nara Netralaya, Bangalore, and she has another interesting case to show. On to you. We have 3 more speakers. I think we have to go fast. Yes.
Thank you, ma'am. Am I audible?
Yes.
So I'm sharing my screen now. So today I'll be presenting one of my cases, which was partly done by one of my fellows and then later taken over by me. I'm very thankful to Chitra ma'am for this opportunity. Starting with this particular case, if you can see some phacodonosis, it was actually not present during diagnosis. It was actually missed, but the fellow started doing the surgery, main ports and side ports were made. And while during rhexis, this is when I noticed this area. And my first caution sign was to my fellow that please take care. This looks like a little danger sign coming over here. and rotation was okay while during hydrodissection. This is the second time when I noticed that the lens was tilting, and my second warning went to my fellow that, okay, you have to be very careful while you're doing your chopping. And you can see whenever the chopping is happening, and it is a grade 4 cataract, it is causing the lens to tilt a lot. And during this time, the chopping was initiated. We had reduced the parameters and while doing the surgery. And by the time the first piece came out, then this was the time when the nucleus had to be rotated for taking out the subsequent pieces. And this is the time when I felt, okay, now this is where I had to kind of take over the case, and I realized that, okay, we will have to salvage it now. So I've put viscoelastic over here, I've used viscoat, and this is when I have put a CTR over here. One of the main reasons that CTR was put over here and not hooks was I was comfortable putting the CTR to an extent that I knew that it was a very localized ZD, and taking out the pieces was easier with this case. Now here, when I have taken out my phaco probe, I realized that my pupil is still distorted. My bag is intact, but at the same time, I can feel that my pupil is getting distorted and it is enlarged. And that is the reason, that is the time I realized that doing vitrectomy will have to be done, although it was just maybe 2 strands over there. But the moment vitrectomy was done, the pupil was nice and round again. And once it was done, this is the time we were able to implant hydrophilic IOL over here without any difficulty. And this was put in the bag. So one of my take home, and then this was okay. I mean, after doing hydration, I was able to close the case. And this is the first day post-op surgery photograph. So with this, there are a few points which I feel that I have always tried to focus on, is that whenever we have, I'll just stop the share now. So one of the few points is like, whenever it is a brown cataract, it is always like, it comes with handle with care instructions. It can behave very differently. Second thing is vitrectomy, even though with a intact bag, will be required in some cases. And third is that we need to lower our parameters while we are doing surgeries. So yeah, now I'm open to discussion. I mean, anyone would like to tell.
Nice video, and well managed. And a challenging case. It was a very hard cataract. It's just that the minute you notice the ZD, you may not use a CTR, but you could have used capsular hooks.
Capsular hooks.
Because there's a lot of maneuvering which was needed. And then after the whole of the cataract, when you realize that there was a dialysis there, you could have injected tricot and stained that area. And I would, if it's a very small area of dialysis, I would prefer to take my IA and my vitrectomy cutter both through the 2 side ports and not go through the main port, because that could cause shallowing and more vitrectomy forward.
Yes, ma'am. So that was one of the reasons, because I could see one bolus of vitreous exactly between my left side port and the main port. And going from that area was easier for me instead of going from the side port. So that is why I did it that way. But I totally agree with your points, ma'am. Totally agree.
And I would also say that you are a very bold assistant. You are by letting your trainee, to after seeing the first time, second time, and obviously third time, there is another area of dialysis. Still, you say, I am issuing warnings. I am issuing warnings. You continue.
Exactly.
Such a bold lady.
So you can ask my fellow. I think she must be online. You can ask her, sir. I was trained that way, sir. So
yeah, that is quite bold. But then at the first point of seeing that area of dialysis, I would take some preventive measures not to enlarge it and get more vitreous out. Initially, it was not out vitreous. So I would start processing in the beginning itself, rather than issuing warnings to our trainee person.
Thankfully, it was about 2 clock hours of 2 clock hours of ZD, which I could see. And even after vitrectomy, thankfully, the bag was very stable. And that was one of the reasons that I did not use iris hooks. Sometimes I've had one experience in which I was able to complete the surgery after putting the hooks. But that was the time when I realized that the bag was so unstable that by the time I was able to put the lens, the whole bag was trying to come out. So I would prefer to put CTR initially in this particular case. Of course, all cases are different, sir.
Yeah, very good case.
It's a cataract which is so hard and brown. I think putting a CTR at the beginning tends to make the management of the nucleus a little bit more difficult. Then I agree with you, Chitra, that I would put in capsular hooks right at the beginning, moment and notice the zonular weakness, so that the CTR can then be inserted more comfortably after having managed the whole nucleus and the cortex. Just a small point.
One last thing is, I feel if the surgeon is comfortable placing CTRs and the part of the nucleus is out, some surgeons can easily place and very skillfully place CTRs like she did in the back. That is also actually acceptable. If some people feel, I also feel very safe when the CTR is inside and the whole thing is stretched out and you don't get any movement there and you don't see vitreous often. So some people are very comfortable after the CTR is gone in. And if they can place well, I would say at your comfort, I think surgeons should be placing CTRs at your.
Thank you. We shall now go on to our next speaker, Dr. Deva Prasad, who practices at Prasad Eye Care Center at Rajaji Nagar, Bangalore. And he has an interesting video to show us. On to you, Dr. Deva Prasad.
Yeah. Good evening to one and all. At the outset, I would like to thank Dr. Chitra Ram for giving me a chance to present. I'll be sharing my screen. Is my screen visible now?
Yes.
Yeah. Okay. I just want I just wanted to highlight few points in this case. This was a one-eyed cataract with coloboma. So initially, I thought I'll do a phaco in this case, and I stained the anterior capsule with trypan blue dye. You can see that there's a very good retroillumination, which is suggesting that the cortex is not that opaque. So as I started my rexes, I could make out that the capsule is very elastic and it is very difficult to finish the rexes. So when I was doing the rexes, actually it was going haywire. So I decided I'll just prevent the rexes from running away, and then I could complete my rexes. I could at least complete it 360 degree. So once the rexes was done, I decided that I will not do a phaco. I will do a small incision cataract surgery, and I went on to do a sclerocorneal tunnel with a crescent blade. Once the sclerocorneal tunnel was made and AC was entered with a keratome, care was taken not to touch the anterior capsule at any point of time because the axis was not intact. Then a cortical cleaving hydrodissection was done. The cataract was very dense in the center. So I removed it with the dialer and a vectus. So it came out very easily. But the problem started after I delivered the nucleus out. I could see a very, very dark glow, and I was totally confused what to do because I was not able to differentiate between the capsular margin, the cortex, or the posterior capsule. So this time what I thought was to put a IOL in the beginning itself. That is basically a IOL scaffold, so that the lens is inside the bag, the IOL is inside the bag, and then do the rest of the procedure later. So once after putting the lens inside the bag, then I started removing the cortex, though it was a very tedious process of removing the cortex after putting the lens, but I was able to do it successfully. And slowly you can see the chamber was collapsing. There is a iris coloboma at the inferior part. So I was expecting some zonular dialysis as well. So took some patience and then started removing the cortical matter one by one. So 1 second. Yeah. And after that, the IOL was very well centered. And then the rest of the cortex, little bit of things are near the zonules were then aspirated out. So lastly, the subincisional cortex was removed. And then finally, this is the end of the surgery. And finally, I could complete the case. And the side ports were hydrated. And the patient, because patient did extremely well on the first post-operative day, though he was one-eyed. That's the end of my case.
Yes, thank you, Dr.
Thank you.
Devaprasad. Just one or 2 points which I want the expert panel to comment on is creating the side port at the location of the coloboma. There could be a fluid misdirection in that particular area and may not be advised. And what are the thoughts of everybody for placing a CTR if there is a coloboma is there? Anyone, Dr. Meenu Mathan, Dr. Nitin?
Yeah, if it's a very localized one and if there is a few zonules lost in that small dialysis area, I don't usually place a CTR. And rightly, as you said, you can have fluid misdirection, vitreous coming out, especially if you place the paracentesis exactly there. So if I'm doing temporally, I would go supra-temporally or little away from the temporal side and then place a paracentesis which is away from the area of zonal dialysis. But phaco, if the pupil is dilating well, phaco also is okay, but what is convenient to you is the best way to do it on that particular day for that particular case. But otherwise, this is well done.
Thank you. We shall because I'm going to go on to the next case because we have 2 more speakers. I would invite Dr. Nikhil Balakrishnan, who is again a young ophthalmologist from Sai Deep Eye Clinic and Crystal Vision Center, Mumbai. And he has another very interesting teaching video for us. And let's hear from him. On to you, Dr.
Thank you so much, ma'am, for this opportunity to present my case on this platform. So this is a case of a posterior polar cataract. We had done an anterior segment OCT preoperatively to see if there was any kind of dehiscence of the posterior capsule preoperatively itself, but there was none found. So when we proceeded with this case, we went ahead with a normal posterior polar cataract with a grade 1 to 2 nucleosclerosis. We went ahead with the normal steps here, created a roughly roundabout 5 to 5.5 millimeter excess, keeping in mind that if in any case the posterior capsule gives way, we can place the IOL in the sulcus itself. So it was an uneventful rhexis that we could perform here. Following this, we went ahead and did a hydrodelineation at multiplanar hydrodelineation. You could clearly see here we got a golden ring sign, which is at multiple planes. We went ahead by chopping the nucleus. Now here we could get good central first chop, but the nucleus wouldn't rotate, obviously, because we hadn't hydrodissected the nucleus at all. So just by changing the direction of the phaco probe in multiple planes, we went ahead and chopped the nucleus into multiple pieces. Once we did that, we tried to grasp the multiple small pieces of the nucleus and eat them up itself. We were successful in doing that and eating the multiple small pieces and could eventually get out the entire nucleus. And what remained back was just the epinuclear plate at the end of the process. So at the end of this, you can yet see the posterior polar cataract adherent to the posterior capsule. We went ahead with cortical aspiration here, irrigation and aspiration with a bimanual irrigation and aspiration. I tried to loosen out all the epinucleus from all the different quadrants so that the entire epinucleus could be extracted out at one go itself. So here I'm individually extracting out the epinucleus from all the quadrants. Because we hadn't done any kind of hydrodissection, it was very difficult to separate the epinucleus from the capsule overall. And I found it a bit difficult here. I was struggling to get that out. So multiple attempts were made to do so. I could free it from almost 270 to 300 degrees, but particularly under the right side port, it was found to be difficult. I tried to find a free edge wherever I could get a free edge of the epinucleus so that I could extract it from there. Eventually, after trying a lot, I found a free edge there. And when I tried to extract the epinucleus out, I thought eventually I could manage to do that. But unfortunately, I pulled out the bag too slightly. So we see here that along with the epinucleus, I've pulled onto the bag too. I made an amateur mistake by not inserting viscoelastic before bringing out my irrigation port. Immediately inserted viscoelastic, and I noticed that the pupil, the rhexis margin had come inside. I went ahead and placed a capsular tension ring into the bag, making sure that the eyelids of the CTR were away from the side of the zonular dialysis, and dialed the CTR successfully into the bag. And then went ahead and carefully tried to extract the entire epinucleus out, again shifting hands with my bimanual irrigation and aspiration, and slowly and steadily ate up the entire epinuclear plate. Following this, I implanted a hydrophobic IOL into the bag itself, following which there was good support, and the IOL was very well centered. Dialed the IOL into the bag properly, and then closed the case.
Yes. Well done case, Nikhil. You showed us something which happens in a polar cataract, where the epinucleus is very difficult to tease out, and you find that, of course, you had a zonular weakness to add to the challenge. But at that point of time, could you have tried viscodissection and sort of done that, because the bulk of the nucleus is out? Could that have happened? But the epinucleus could be very adherent. The viscodissection might not also help in cases. I don't know. Of course, it was a very small area of dialysis, so a single piece lens with a CTR would suffice. But otherwise, you could use a 3-piece lens, unless it's a toric IOL or something where you have to do a single piece lens in that particular case. Anybody's thoughts, Dr.
Nikhil, Nikhil, very well done, Rexes. But I would say that 5.5, if you do capturing a 6mm properly, it's not that very easy. So next time you do a 5.5 and put in a 3-piece and just see, it will not capture that very easily. So it has to be close to 5, maybe a slightly onto the 0.1 to the other side of 0.1. It has to be 5, close to 5, to maybe slightly less than that. So that is one point. Second thing is, he has very clearly told us that epinucleus, when it's difficult to aspirate, you get irritated, you get frustrated and pull on the bag. This is what happens, and it has happened to all of us. We all know. We will go to the equator and pull. So as Madam was telling, viscodissection many times helps. Only thing is that we have to be patient enough, and your location has to be exact, that you are under the anterior capsule, close to the equator, and bolus of injections of dispersive viscoelastic into the equator, so that you'll see the movement. And it has to be done in different directions and from different angles. And in between, you have to reduce the chamber volume by burping out the extra visco is come in the anterior chamber, so that you can. And also, otherwise, what I do is to use the chopper, my blunt tip chopper, which is 1.75 to 2 millimeters long. I take it. I don't place it like this. I turn it around like this. Go underneath the rexus margin and sweep around at the equator. It nicely brings out the sort of movement, at least from the periphery, and then you can start bringing it out. And or you could even place the irrigation. See, once the bag is empty, if you place an irrigation underneath, it doesn't open up the posterior capsule. It doesn't cross any bag. So you can hydro itself by placing your irrigation at different angles at the anterior capsule margin itself. But well done and controlled very well, Nikhil. You have done well.
And for a young guy, you kept your cool and did all the right things.
Exactly. He said an amateurish movement. Very nice way to express that. An amateurish way of taking out irrigation without visco. So always replace visco when you don't have irrigation with the dialysis.
Right.
Congratulations, Nikhil. I think you learned something more while presenting the case. So now go on to our last speaker, Dr. Santosh Agarwal. I'm so sorry, I never realized that I had put you as the last speaker. You know, keep entering the names it happened. And he was a senior consultant from Sushil Netralaya and Dental Clinic, Aurangabad. And he's going to show us yet another case. On to you.
Not at all. I am fortunate enough that I have got the opportunity to present in front of the stalwarts. At the outset, I thank you and good evening, everybody. My case is of a cataract surgery, simple cataract surgery, phaco surgery, but I could do CCC in this case very comfortably. But suddenly I got vitreous subthrust and the AC was getting shallow and iris was coming out through the wound. So I started mannitol, everything, but I could not succeed. So what I did, I will show you. It's a voice on video, very short video. In case I could do CCC very well, but suddenly there was a rise in IOP
and iris was prolapsing through the wound. I tried all the methods to reposit it, but it was in vain. So I planned to do 23 gauge vitrectomy. So I applied the trocar cannula 23 gauge and I did a limited anterior vitrectomy to relieve the intraocular pressure. So it was the venting of the pressure through the trocar cannula, and I succeed in that, and I could insert the phaco handpiece. There was little pressure remaining, so I again did the anterior vitrectomy, and over the visco inside the anterior chamber I could form the AC, and I also could succeed in inserting the phaco handpiece inside the anterior chamber. And then the usual nucleus management was done. There was no vitreous upthrust was found, and it was very easily I could manage the nucleus management. But again, alas, there was another obstacle. You could see the PC range, big PC range behind. So I did the nucleus management slowly, delicately and gently, and I could remove the last piece of the nucleus without any problem. There was hardly any vitreous in the anterior chamber because previous vitrectomy has saved me from that complication, and I could remove the last piece of the nucleus. Now you can see very well the big, large PC range with hardly any vitreous in the anterior chamber. Now I did 23 gauge anterior vitrectomy thoroughly. I removed all the cortex which is behind the anterior capsule, all the adhesions and vitreous in the anterior chamber and the posterior chamber. I removed, I cleaned the space for the IOL implantation. I planned for sulcus fixation of IOL, and
Could you see the video very well?
Yeah, we saw the video. That's just the last bit of IOL implantation, sulcus. We didn't see
Yeah,
it.
that was sulcus fixation. IOL was done, ma'am.
It is just that sometimes, when you inject a lot of viscoelastic and that get the iris coming out, that kind of a floppy iris situation might mimic an intraoperative hard eye, but it need not necessarily have been an intraoperative hard eye. It could, because I saw you injecting viscoelastic and the iris coming out. I mean, just another possibility is there. You have to unmute yourself, Dr.
Hydrodissection was not done, no? Hydrodissection was not done. Before
Yeah,
itself, iris was coming out.
Yeah, iris was coming out.
Viscoelastic itself, yeah, hydrodissection before injecting viscoelastic itself in a small eye can cause, but
Yeah.
was doing a pars plana, I mean, doing a post PPV did make sense to make it a more thing, but I think even the PCR could have been done caused by the touch which could have occurred on the posterior capsule by doing the pars plana vitrectomy.
But
So
madam, generally,
that was
generally, if you generally when they do this vitrectomy, they always place this vitrectomy cutter facing down. But
Yeah.
if you had noticed very carefully, when the later half of the nucleus was coming out, you could see a white plaque on the posterior part of the nucleus. There could have been a posterior polar component behind, and the classical opening of the posterior capsule is like the two straight lines. So it could have been a cut by the vitrectomy cutter will not create this kind of a linear opening, and it could have been a posterior polar cataract. And doing a pars plana vitrectomy is fine, but only thing is that we don't know whether it's a fluid misdirection or the visco which has increased the pressure in the AC and pressure iris or suprachoroidal hemorrhage. So somehow at some stage, if there is any doubt of suprachoroidal hemorrhage, we need to rule that out before doing an anterior vitrectomy.
Instead, you could give an injection mannitol on the table and make the
that he
eye.
tried is what he said. I think he said he tried,
ma'am, but it takes a lot of time also. Half an hour at least we need for that. And in also lens-induced glaucoma cases also, we can do this type of pars plana and limited antivitrectomy.
Yeah, that's
and
a
not
great
going
technique.
to the posterior of the capsule, just venting, only venting of the vitreous, whatever is coming through the pars plana opening.
Yes.
This is a procedure very well demonstrated.
Points, actually.
Yes,
This is a procedure which is very well demonstrated.
Dr.
with
Satyan wants to say, and Dr. Nitin. We'll hear both of you. Yes, Dr. Nitin.
Yes, like I said, this is a procedure very well demonstrated with Dr. Stephen Safran from the US. He always does a core vitrectomy in all these cases, just a small core vitrectomy. In fact, even in the subluxated cases, he believes in doing a core vitrectomy. And it really works well because you're decompressing the eye from that particular area.
Yeah. Dr. Satyan, you had something to tell?
Yeah, see, when the patient is complaining about severe pain when you're doing the surgery and when the AC is becoming shallow, that's very typical of suprachoroidal hemorrhage. Identify that the pain component from the patient. If we know that, then it is easy for next step to be done. If without knowing that, if you just go and do the pars plana or antivitrectomy, whatever you do, we are going to complicate the things much more. Like what you all said was possibly there is an increased viscoelastics, amount of viscoelastics which you inject is higher. It is always a possibility that you keep seeing that the iris keep coming out. So that is one thing which we must remember. And also there is a controversial role of the IV mannitol when you have a possible suprachoroidal hemorrhage. The idea is you make it tighter so that there is no more bleeding. But when you reduce the volume by giving the IV mannitol, you are trying to give a more space for it to expand. So it's it's not a very ideal way to do. And when you have a shallow chambers, in one eye if you have faced, other eye also you have to face.
Yes. The one eye it has happened, the other eye also you have to decongest the vitreous pre-operatively before you take up these cases. Yes.
Actually, patient was very tense intraoperatively. He got anxious and he stopped his breathing for some time. He told me later on that happened.
Was it topical or was it under block?
Topical. But later on, I injected some subtenon's injection also. Lignocaine for my trocar cannula purpose.
Yes, Dr. Satyan. Add that one more point. Yeah. Yes. See, if you have gone through halfway through before keeping your IOL, sometimes you'll have a very shallow chambers, very tight eyeball. Don't do anything, and then just leave it. Put atropinize these patients even when you're taking the patients up for the next visit. It is better you atropinize and then take these eyes, they will do very well. But without atropinization, again, you face the same.
Yeah. Yes. What he said are valid points for the second eye. What can be done? Yes.
Fluid misdirection through loose zonules is not at all uncommon. That is very, very common is what we need to understand. So towards the end of IA, you may suddenly feel that the PC is bulging up and you're getting this. So it happens in many cases.
Yes, yes.
Well done, sir. Well done. Very well done, sir. This is the scariest situation you can do. Yes.
Chitra, I would like to present my point of view in such cases. If you face such a condition during surgery, you have very limited time. What surgeon did was a very good approach, but I would like to do it in a different way. First of all, I would like to take out the viscoelastic by putting two side ports and getting my bimanual aspiration, irrigation aspiration. You take out whole of viscoelastic, try to push the iris inside. If your eyeball is stable, give one suture, give a retrobulbar injection or peribulbar injection, give a slight massage. This will bring down the tension.
Yes.
And many a times you can manage it simply by taking out the viscoelastic, re-injecting it again.
Yes. Yes, very true. That's a very practical. We've done all these mistakes and become better out of these mistakes, which is It is not that whatever we are talking is theoretical, all personal lifetime experiences. And I think, I'm sure my expert panel would agree that we definitely saw a very, very interesting variety of cases in the last 2.5 hours. You know, just so many cases, so many points, such valid points. And believe me, I don't know how much others learn. I keep on learning from all these webinars and the discussions which follow. And truly, we have an amazing set of surgeons in our country, and the confidence with which they show these videos, truly kudos to them. And I'm sure all of you will understand how amazing our expert panel were in this meeting, and the kind of learning and inputs it just comes pouring out. And 3 cheers to our expert panel, and 3 cheers to our wonderful set of videos and superb speakers who each of you all delivered it with such great confidence. And I need to thank the AIOS admin headed by Kripal for all the help which they give us. I need to especially thank Mr. Sai and Manjula from Numerotech for all the mails which hit your inbox. But then I believe that there is somebody in different corner of our country who would want to watch these webinars and learn from them, because it's truly a lot of learning. Very special thanks to Mr. Sunil. Can you see how impressively he leads the webinar, happen one after the other, and his intense involvement. So thanks a lot, Mr. Sunil. I have to meet you sometime to personally thank you. I have only seen you on these webinars. And next, of course, I need to thank deeply thankful to Entoad for sponsoring all our webinars over the last near 3 years. And my very special thanks to my wonderful ARC co-moderator and all the other KRC panelists, and any one of them can run these webinars as well or better than I do. So thanks a lot to all of them. And finally, thanks so much to the delegates who have watched these webinars. It is your numbers which I see at the end of the webinar and over the months in the website and YouTube, which always drives me forward to keep conducting these webinars. Thank you very much, one and all of you. Mr. Sunil, you have to tell us how many have watched this webinar without fail in the next 10 minutes. Mr. Sunil, are you there? I think he's not there at this point of time. Thank you very much. Thanks a lot, all of you.
Madam. Thank you so much.
Thank you very much.
Thank you, ma'am.
Thank you,
Thank you, everyone.
Thank you, madam.
Thank you so much.
Thank you, madam.
Bye.
Thank you.
Bye.